Lucy, are you able to hear?
Yes, everyone's here. All right, let's go ahead and kick the February 24, 2022 meeting. Let's kick it off officially. Susie, can you please do roll call?
Yes, Chair.
Yes, Chair.
Chair Delgado.
Chair Delgado.
Here.
Vice Chair Lucy.
Vice Chair Lucy.
Here.
Michael Brown.
Michael Brown.
I think we just lost him, maybe. I just saw him.
Yeah.
Christopher Dare.
Christopher Dare.
I'm here.
Dr. Dinko.
Dr. Dinko is not logged on yet.
Novak.
Dr. Novak.
I'm here.
Dr. Clacking.
Dr. Clacking.
Chair, we have a quorum.
Chair, we have a quorum.
Okay, and I see Mr. Brown is back with us.
Okay, hear me.
Pledge of Allegiance. Dr. Clacking, can you please lead us in the pledge?
Yeah. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, liberty and justice for all. Thank you.
Item 3, approval of the agenda. District Health Officer, any changes with the agenda?
No, Chair Delgado, we do not have any changes.
Okay, I'm looking for a motion from the board.
Move to approve. Christopher Dare.
Second.
I have a second. All in favor?
Aye.
Aye. Any opposed? Motion carries. Moving on to item 4, recognitions. District Health Officer, please.
Yes, thank you, Chair Delgado. I'd like to begin with years of service and pleased to recognize Susie Valdesman, our administrative assistant for the Board of Health and Office of District Health Officer. Susie has 20 years with the county and the health district. So congratulations and thank you, Susie. Also want to recognize Carmen Mendoza, Office Support Specialist with our Vital Statistics Program in EPHP. Carmen also has 20 years with the health district. And Christine Ballou, an advanced practice registered nurse at CCHS. Christine with 5 years of service. So congratulations and thank you to each of those individuals for their service. I have some new hires also that I wanted to introduce you to. We have Carmen Augusto is a new addition to the Office of the District Health Officer in 2017. Carmen received her Bachelor's of Science degree in Community Health Sciences and Public Health and a minor in Business Administration from the University of Nevada, Reno. After obtaining her bachelor's degree, Camarina began her career at the Washoe County Health District as an intermittent health educator in the Community and Clinical Health Services Division, where she focused on chronic disease prevention. After some time as a health educator, Camarina moved to San Diego in 2019 to obtain her master's degree in public health with an emphasis in health and behavioral science. Camarina is excited to be back at the health district and is looking forward to her new role as the health equity coordinator. Also want to welcome Shannon De Silva with EPHP. Shannon De Silva joined our Epidemiology and Public Health Preparedness Division on January 31st, 2022 in the capacity of the Office Support Specialist for the COVID unit. For the last decade, Shannon has worked in the environmental nonprofit sector and for the International Ocean Carrier. She supported environmental leadership programs in the Arctic and Antarctica with a global focus on climate change. Shannon is currently a graduate student at the University of Arizona studying MLS, environmental law and policy. Outside of work, she remains active in her local community and sits on the La Sierra Chamber of Commerce Board, Fire Safe Council Biomass Group, and serves on the grand jury. She's looking forward to serving our local community in her new capacity, and she's excited to connect with the Washoe County Green Team as minimizing and educating others regarding environmental impacts are some of her greatest passions. Also want to welcome Sabrina Russell. Sabrina's joined the Washoe County Health District as the EMS Coordinator. She is originally from San Jose, California. She graduated from the University of Nevada, Reno with her Bachelor's of Science in Biology. Her career endeavors have included emergency veterinary medicine, nutraceutical manufacturing and quality control, and most recently, emergency management and compliance in a healthcare setting. She was most recently at a federally qualified health center here in Reno, where she focused on emergency management and compliance, all within the scope of health equity. She's had a large role in quality improvement and process change for compliance. She loves winter sports, spends her free time snowboarding and playing ice hockey. And she's looking forward to learning more and her experience in her new role. Also want to recognize Joseph Cook in Community and Clinical Sciences. Joe comes to the Health District with a bachelor's in sociology and is certified in basic law enforcement. He's a military veteran with 7 years of service on active duty, where he worked with the U.S. Marine Corps and the U.S. Army. He plans to pursue a master's in public administration. I also want to welcome Jamie Morales, who came to the Health District with a significant history of working for Washoe County. She started her career with Washoe County Senior Services in the role of community health aide. From there, she transitioned to working for Washoe County Social Services, where she was a human services support specialist. Want to also welcome Manuel Coronado. He is new to the CCHS as an OA2 for the COVID immunizations. He comes to us with a knowledge about our county operations. He worked for the Public Guardian's Office and the County Clerk's Office. He also worked for the Washoe County School District. He immigrated to this region from Guatemala at the age of 9 and has lived here ever since. He's a proud father of 4 and enjoys the great outdoors and traveling. And also want to welcome Hector Mendoza Marin with CCHS. He's had several years of customer service roles throughout his work history. He's worked as a tour guide for the University of Nevada, Reno, and has done technical support for customers of various ages and interests. He has been in sales for many years, which made him comfortable interacting with people. He's very excited to work at the Health District because the environment seems to be fast-paced, which is an environment he tends to thrive in, and he will be contributing to the community's well-being. So those are our new hires, and congratulations to all of them, and welcome. And I also have some promotions. I want to recognize Catherine Olson. Kat successfully passed the REHS exam, Registered Environmental Health Specialist exam, in December, which led to her promotion from a trainee to an REHS. And Kat has been with our EHS for approximately 2 years and is a valuable member of the food safety program. Also want to congratulate Gloriana Alvarez on her promotion. She's been promoted to Department Systems Specialist. She joined the Health District in October 2021 as Department Systems Technician. She has 8 years of experience in tech support and is currently working on her bachelor's in software engineering. In her free time, she likes to read and spend time with her family. Also want to congratulate Christina Shepard in CCHS. Christina was promoted to nurse practitioner supervisor. She's been a nurse for 21 years and an advanced practice registered nurse for 5 years. Christina started her career at the Washoe County Health District in 2016 as an advanced practice registered nurse in our family planning program. She transferred to Human Services Agency in 2018 to work at the Child Advocacy Center and rejoined our family planning program in 2020. She spent the majority of her nursing career in neonatal intensive care, where she was a nurse leader. She will be supervising the advanced practice registered nurses in our family planning sexual health program, and she will also supervise 3 community health workers that we are in the process of recruiting for hire. So congratulations to those 3 individuals for their promotions. And I will turn it over to Francisco Vega, who also wants to recognize some of our Air Pollution Control Board members' retirements.
Thanks, Kevin. Can you hear me?
Yes, we can.
Okay, perfect. Yeah, I'd like to recognize some longstanding members of our Air Pollution Control Hearing Board, and maybe just a little bit of background. the state of Nevada or any of its political subdivisions and are recommended by the Air Quality Management Division and approved by the District Board of Health.
Okay, so
One of the members
it's in
is an
this
attorney,
computer, Steve.
one is a licensed
This
engineer,
computer
and
is
the other
not
one is a
putting out
licensed
sound.
contractor. The remaining
So-
members are at large. What the Air Pollution Control Hearing Board does is they're a fair and unbiased panel that hears appeals when a negotiated
They keep reading
resolution
some
to
on
an
my phone.
air pollution complaint cannot be achieved.
It's just the sound.
These
in this
members
computer's not working.
volunteer their time and play a really critical role
So I had
in
to
making
call
sure
myself.
that the Air Quality Division is held accountable for its decisions. It's a really important role, and again, these members volunteer their time.
I turned the
So first, I'd like to recognize Kathleen Fitzgerald, who served on the board for 12 years. And I believe Ms. Fitzgerald is here, so maybe she can speak a little bit on her own behalf.
Try to check the sound. It won't.
Okay, thank you very much. It has been my honor and privilege to serve on the board for the last 12 years. And I also served back in 1994 to 1999. And the only reason I left was to join the Peace Corps to do clean water projects and sanitation projects in Bolivia. But back then, we had meetings every month and 2 to 3 cases per meeting. And now in the last 12 years, we've had maybe 2 or 3 cases per year. And that's a tribute to the great work and dedication of the staff and the director in putting together the cases and documenting the violations and working with companies to on the amounts of the fines. And so now there's really no reason for appeals. I also wanted to give a shout out to Janet, who has been there since I was first on the board in the 1990s, who keeps things running smoothly and efficiently and keeps everyone on track during our meetings. And again, thank you for allowing me to serve on the board. It has been a real pleasure.
Thank you, Ms. Fitzgerald. Next, I'd like to recognize Jeannie Rucker, who has served on the board for 9 years, from 2012 to 2021. I didn't see Ms. Rucker on the list there, but if I missed it, Ms. Rucker, if you would like to speak on your behalf.
Right.
Okay. Yeah, I wasn't sure if she was going to be able to make it, but thank you, Ms. Rucker. Lastly, I'd like to recognize Jim Kenny. Mr. Kenny served on the board from 2013 to 2022, and again, really provided an important service for the board. I know Mr. Kenny had planned on attending, but I didn't see his name on the list either. But Mr. Kenny, if you'd like to speak. Okay, not hearing them. But again, I want to really extend my sincere gratitude to these members. Again, they volunteer their time to these important cases and their decisions, and it's a really critical role that they play in this community. So thank you very much.
It's just a, you know.
All right. Thank you, Francisco, and thank you very much to all of the Air Pollution Control Hearing Board members that are now stepping down. That concludes our recognitions, Chair. If you'd like, I can go to our next item, presentation.
Yeah, thank you, District Health Officer. Yeah, but first, I want to acknowledge and thank you again to all those new members and those that have been with us. Look forward to working with all of you. In particular, I'll point out that Sabrina is a great pick, and just wanted to pick her because you guys stole her from CHA, but I'm glad that she's able to provide more to the overall community. So great pickup. With that, we'll close item 4, move on to item 5. District Health Officer, go ahead.
Yeah, this next item is a presentation and recognition of Patagonia and Care Chest of Nevada for their Green Business Awards. And I'd like to turn it over to Wes Rubio to lead this, kick this off.
Thank you, Health Officer Dick, and hello, Chair, members of the board. For the record, my name is Wes Rubio, Supervisor, Environmental Health Services. I'm here to present the Green Biz Awards for 2 local companies who have made the amazing efforts to become Tier 3 innovators. So that I am going to share my screen. Why is it not coming up?
We're seeing it.
Are you?
Yeah.
Oh, well then I wasn't. So now I am. All right, so Green Biz Awards for the Tier 3 Innovator recognitions. Once it moves forward. So we partner with KTMB and Nevada Green Business. They implement sustainable practices. It is a voluntary certification process. It is trackable, and KTMB and our other partners provide focused education assistance to all the businesses that enter going through any of the processes. The process includes 3 levels of certification. Some people may be kind of aware of them, so I'm going to briefly cover them. They're Tier 1, Tier 2, and Tier 3. Tier 1 is your basic recycling, alternatives, driving alone, turning off equipment, modifying basic practices to boost up those efforts. Tier 2 are business sector specific. They're really focusing on a little bit of technical changes, modifications to business processes and industry. Tier 3 is our highest level. They allow for the businesses to really get to where they need to be. And there we go. Make it bigger.
So, yeah, Mr. Rubio, we're just seeing the intro slide. So,
well, that's why my director's in here trying to figure that out as well.
okay, just want to be aware.
Well, I did change the screen. You know what? We'll just go with it. This helping?
That's it. Yep.
Okay. Well, then we'll just do it this way. There's always solutions. So with our first person, or our first company that we want to talk about is Patagonia. They worked with KCMB and Green Biz to really advance their practices and kind of jumped in. They are a Tier 3 innovator. They were established in Reno in 1996. They have a massive global distribution center here. They employ 20 individuals locally in the community. And obviously, I'm pretty sure everybody is well aware of their outdoor clothing prowess and the benefits that their clothing does provide. Some of the effects that they did was they created a worn wear program. So their customers are able to have clothing repaired for free. They can sell back items. They have modified and laundered their the clothing that does come back. So it goes back to at discounted prices. Essentially, this does exactly what some of our programs here at the Health District really want them to do, which is create a sustainable diversion to landfill practices. Some of the successes that they've also implemented were a drive less program, so they incentivize driving less. They've also, they incentivize that for $2 per trip for walking, biking, carpooling, public transit, et cetera. And that has led to a 30 to 50% change in alternative transportation practices to their facility. Getting to Tier 3 has not come without challenges. Some of those challenges for this particular industry were zero waste initiatives are difficult. As we all know, clothing and merchandise comes in shipping. So it's very difficult to become zero waste when you're generating waste inherently in your practices. So they have worked through some of those things. They relocated trash and recycle bins off of their sales floor. They're changing the habits, and simple changes like that really do modify and start changing behaviors, which is the goal of where we're heading eventually. This led to over 40,000 pounds recycled between plastic and poly bags, and it goes back to a local company produced decking material, and that company is local, and we have worked with them on other projects as well. Some of the next steps for Patagonia are to further their efficiency goals. They want to continue to make some lighting changes as their opportunities arise. They want to continue to go for a greener footprint. And again, incremental changes to a greater goal, they will help get there. It's small steps, but it's always moving forward in a really positive way. The next business we want to recognize today is the Care Chest of Sierra Nevada. It's medical resources for Nevadans in need. They're a 501c nonprofit. They are local in Reno. They provide free medical resources, durable medical equipment, and supplies to low-income Nevadas. They've been doing this for over 30 years within the community. Their big advancement over the last few years has been recycling medical equipment and diverting again. So they've done over 2,000 pieces of medical equipment that are recycled or refurbished. They're able to divert this to either be reused or remanufactured. And they've also implemented a massive green or solar project on their property. They produce 1,500 kilowatts per month, which is a huge benefit to them and their practices locally. Again, some of their challenges, like everybody else, different challenges. Some of the challenges that we've also faced over the last few years. Sustainable and safe cleaning products are not always applicable to every industry. So it's kind of a challenge to find EPA listed cleaning products that are good for medical equipment. So they had to balance, and they had to figure out a good way of balancing what the needs of the community were going to be for going green and what the needs of the business industry are for using those appropriate cleaning methods. Gloves, one of the big ones. And again, this is something that is dear to my heart as well, because I face the same challenge. It's really hard to recycle gloves and some of the medical equipment. They have found some really good methodologies to try and divert that waste from the waste stream. They're using non-biodegradable, or they stopped utilizing non-biodegradable gloves internally and for community members that they're assisting. So they've really stepped up in different ways. So everybody has their own challenges that are unique. So getting to tier 3, they've increased the awareness for all of their employees, recycling environmental concerns. They have a meeting locally, and it's in for each of their departments in their group as a business. They've added components, low flow faucet, recycling, alternatives, office paper with post-consumer recycled content. So again, small steps to the greater goal, one of the things that we try and target here. So really, just a huge congratulations to both Patagonia and CareChest. They're tier 3 innovators and their commitment to public and environmental health in Washoe County. So without these programs and success, we wouldn't be here. We wouldn't be able to continue moving forward with our partnerships locally. So I really want to thank them and KCMB for providing the continued education and hands-on resourcefulness to all of these businesses. Thank you very much. Thank you very much. And that should be it.
Thank you, Wes. Great. Thank you for highlighting those businesses. In particular, thank you to CareChest and Schiller. Appreciate all the work that you guys do and your team. You guys do an amazing job in our community. I've worked with you guys for years, and you guys have always been so stand up and thoughtful. So thank you. And thank you, of course, to Patagonia. Keep checking those beautiful. And thanks, Rubio. You guys do an excellent job recognizing our businesses and our organizations here in town. Appreciate it. Thank you guys so much. With that, we'll close item 5. We'll move on to item 6, public comments. Susie, we'll go to you.
Yes,
Sure. Before we start that, I'd like to read a message. Full public comment is limited to 3 minutes per person and should be addressed to the Board of Health as a whole, not an individual. With the exception of the public comment agenda items, comments will be heard for items labeled for possible action and should be specific to the item being considered by the board. The District Board of Health conducts the business of Washoe County and its citizens during its meeting. The presiding officer may order the removal of any person whose statements or other conduct disrupts the orderly, efficient, or safe conduct of the meeting. Warnings against disruptive comments or behavior may or may not be given prior to removal. The viewpoint of the speaker will not be restricted, but reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant and unduly repetitious statements and personal attacks which antagonize or incite others are examples of speech that may be reasonably limited.
And with that, I would like to place for the record first that Dr.
Denko logged in at 105 chair, and that we have an email from Mr. Len. He sent it in this morning, so I'm going to place that on the record. And we have Ms. Cindy Martinez as the first public comment. If she can unmute herself, please.
morning, board. Thank you for this opportunity. I'm disappointed that you're not meeting in chambers. I imagine that this meeting is either scheduled online for convenience or because you're worried that you cannot capably manage an energetic meeting. Regardless, I would like to ask that this board consider putting in some kind of language into the declarations of NRS 414 that's been declared by the governor, that there is no state of emergency in the county of Washoe, and this board should take concrete actions to implement bans on mandatory vaccines, bans on vaccine passports or any method of vaccine verification that would install any system of segregation or medical apartheid in Washoe County. And we should never again return to mask mandates. There should be the principles of medical freedom that citizens are allowed to observe and exercise, and constitutional protection should be observed. There are 3 elected members on this board who are responsible for having taken an oath of office to the Constitution. So I hold them in higher point of responsibility in that regard. The rest of the people who are on this board, respectfully, you're unelected bureaucrats, unaccountable to we the people. And we are still watching what you're doing with regard to the mitigation and management of this COVID-19 nonsense and the obscene allocation of federal money that is artificially inflating budgets in the county, which is going to lead to financial ruin when all of this house of cards collapses. Thank you.
Susie, before we kick off the next one, just want to let the community know and all those that are listening that we will be back in chambers next month on March 24th at 1 p.m. Just want to let everybody know that we're meeting virtually today because of all the changes. We weren't able to get up and going, or else we would have met in person. So next March, look forward to seeing everybody in person. Thank you. Go ahead for the next public comment.
We don't have any more public comment registered, but I do have Ms. Erin Massengale with her hand raised. If she'd like to speak, if she could unmute herself, please.
Thank you. Good afternoon. I would like to request that we agendize and pass a resolution that bans vaccine passports and any sort of vaccine verification system. I would like us to ban any verification system, not only with businesses and patrons, but we should not allow any business to verify anybody's vaccine or medical status with any employer within the county. It's abhorrent. It creates a 2-tiered system and it violates medical privacy. I also want to state that deaths among the triple vaccinated increased by 495% in January, with the vaccinated accounting for 4 in every 5 COVID-19 related cases, hospitalizations, and deaths since December. Obviously, we have an issue here. Additionally, I would like us to pass a resolution regarding COVID-19 treatments. I provided an example of that resolution in October. Please refer to the information I provided to the health board at that time. And I would also like to state that we should never mandate masks again. There is enough science to verify that they were not helpful. Additionally, there was more damage done during the lockdowns from the mitigation measures, as stated by the Boston Globe. Lockdown measures aimed at preventing the spread of COVID-19 may have had adverse effects on the brain health of even people who avoided infection during the pandemic, according to the new studies from research at Massachusetts General Hospital. The study, the hospital said Tuesday in a statement, was published in the Journal of Brain and Behavioral Immunity. I would like to encourage you to read that. Thank you so much.
Thank you. Next.
Up next, we have Mr. James Benton with his hands up. If you'd like to unmute himself and start speaking, please.
Hi, thank you for this opportunity. I personally would prefer to have an open in-person meeting, so I'm happy to hear that we'll return to this next month. Also, I want to state my opposition to vaccine passports, and I would support a resolution supporting that. Also, I support informed consent by anybody taking a vaccine. And I'd like to see a resolution detailing what informed consent is. That should include the contents of the vaccines and possible side effects, just like what is done with other medicines. Also, I think that we need to be open about the fact that the vaccines have not been effective as we were told they were. In the beginning, we were told, well, we're going to wear masks take vaccines for 2 weeks, we're going to flatten the curve. This did not end, but has continued for months and months, over years. Today, I want to quote from an article by Watch. Dr. Malone states the experimental COVID-19 jabs make the virus more dangerous. If I was in person, I would give everybody a copy of this article. Dr. Malone is pro-vaccine, and this goes against everything liberals say about him. Unlike Big Pharma, Fauci, and other so-called experts, Dr. Malone is all about safety and efficacy. He would never use politics as a resource. Politicians don't know a thing about science. They only care about profit and power. Dr. Malone invented mRNA technology and other NRA innovations while at Salk Institute. He said the vaccine causes the virus to become more infectious than would happen in the absence of vaccination, would cause the virus to replicate at higher levels. We were told that the vaccination would protect you from this virus. And there have been thousands of people that have gotten it. So I just would encourage the board to take up these resolutions and be honest with the people. Thank you.
Thank you. Looks like we have Val W. next.
Thank you. Please put my comments on the record. I'll be quoting from the New York Times article of February 20th entitled, "The CDC Isn't Publishing Large Portions of the COVID Data It Collects." For more than a year, the Centers for Disease Control and Prevention has collected data on hospitalizations for COVID-19 in the US and broken it down by age, race, and vaccination status. But it has not made most of that information public. The agency has withheld critical data on boosters, hospitalizations, and until recently, wastewater analyses. Much of the information that was withheld could have helped state and local health officials, like yourselves, better target their efforts to bring the virus under control. Detailed, timely data on hospitalizations by age and race would have helped health officials identify and help the populations at highest risk. Information on hospitalizations and death by age and vaccination status would have helped inform whether healthy adults needed booster shots. And wastewater surveillance across the nation would spot outbreaks and emerging variants early. There are two sorts of lies: commission and omission. The CDC has lied to all of us, and Kevin Dick has followed the lies, not the science, giving you his recommendations based on lies. He's a bureaucrat, not a medical doctor, and he shouldn't be in the position he holds. What is he going to say to all the families who have lost loved ones because of his incompetence? Oops, sorry about that. The rest of the board is not without fault either. Almost 2,000 doctors nationwide have stepped forward trying to get you and all medical experts to honor your medical oaths and to stop the COVID emergency measures, including vaccine mandates, passports, and the rest. If you truly care about Washoe County residents, remove Kevin Dick from his position on the basis of the incompetence and demonstrated inability to think critically, to analyze complex data, and to serve the safety needs of the Washoe County residents. His resistance to actually think and analyze what's happened in our community has irreparably harmed or killed people. He should not be allowed to continue harming people, now including young children. Thank you.
Any other public comment, Susie? I don't see any more hands raised.
I don't see any more either. We don't have any more registered public comments.
We'll close item 6, public comment. We're moving on to item 7, COVID-19 update and information. District Health Officer.
Chair, I do see one more hand raised at the top, Tom. I just want to make sure that we didn't. Do you not see him?
Yeah, I see him now. Tom, yeah.
Sorry,
Can you hear me? Yes,
thanks, Christopher. Yeah,
Tom, you went back on mute.
do I have to hold it down, maybe?
I'm not sure.
Okay. Hopefully they'll stay. So I wanted to offer what I've got here as just kind of a backup for especially what Cindy Martinez had to say. And most of this is taken from a video from Mike Eden. It's called 8 COVID Lies. If you're not familiar with Mike Eden, he worked for Pfizer for a long time doing lots of different things, vice president of R&D and things like that. But he said that the reason he started speaking out about about what's going on with COVID is that he noticed the British government was lying to people. And first he became alarmed by what he saw, and then he became frightened by what he saw, and he remains frightened. So every country in the world had a pandemic preparedness plan. He read these plans, 20 from G20 countries, plus the World Health Organization. And they had only 2 things to recommend. If you were symptomatic, stay home, wait till you were better, wash your hands more frequently. And the rest of these responses listed what you should not do. They said that there shouldn't be a border closure unless you're a small island. Shouldn't be school closures. You shouldn't close businesses. There should be no mass testing of the well. There should be no lockdown, masking, or anything like that. But all of the things that we were told were essential were missing and explicitly ruled out. The strongest evidence that I can offer my assertion that there is a supranational plan to take over all the liberal democracies is this. All of the countries had somewhat similar pandemic preparedness plans that were very simple, and they all discarded them in the weeks of March 2020 and replaced them with the same narrative script, the 8 COVID lies. The objective was to frighten people to death. How could it possibly be that Germany, Italy, the US, Iceland, Scandinavian countries all got the same bunch of wrong information all at the same time? That's the only way that could be is if they agreed to do it beforehand. Lie number 1, this is an extremely lethal virus. If you get ill, you really could die. But in reality, it's about as bad as a bad seasonal flu. Lie number 2, the PCR test is highly accurate and could distinguish a clinically infected person from someone who is not. The inventor, Carrie Mullis, who won a Nobel Prize for it, said you should never use it for this purpose. It doesn't tell you that they are sick. So when they made this test, they didn't have samples of...
Sorry to interrupt you. You're at your 3-minute mark.
Oh, sorry.
I appreciate it. Thank you. Public comment. Anyone else currently on Zoom that would like to raise their hand before I close public comment? I don't see any hands.
I see no one else.
Yeah, I don't see any. Thank you. We'll close public comment. We'll move on to item 7, COVID-19 update information, District Health Officer.
Yes, thank you, Chair Delgado. First, I just like to remind everybody that the District Board of Health doesn't have any emergency declarations or any mandates in response to the COVID-19 pandemic. The 7-day average for new cases that we have is at 64 new cases per day. That's the lowest that we've had since July 25th of 2021. So that's very good news to see the rapid decline that we've had from the incredible Omicron peak. At our peak, we were reporting in January 1,700 new cases per day. So our disease investigators are able to handle this level of cases, and we have discontinued our automated text messaging system for now because we're able to make contact with them with a live human being. We have 68 confirmed and suspected COVID hospitalizations in Washoe County that are reported today. Our staffed hospital beds are 86% capacity. However, that's primarily driven by staffing being available and other healthcare needs that we have in the community versus COVID-19 patients. So good news there as well. However, our case rate per 100,000 over the past 7 days is at 132.34, and our test positivity is at 16%. Both of these numbers are continuing to drop, so moving in the right direction. We hope to see these numbers further decline because we're still considered high transmission by CDC in Washoe County. We're above the threshold of 100 cases per 100,000 over 7 days and the 10% positivity level. The Truckee Meadows risk meter is currently at high. 64.75% of the population 5 and older has been vaccinated. 74.8% of the population 5 and older has initiated vaccination. And we have 60.71% of our total population vaccinated. 69.46% of the total population has initiated vaccination. About 40% of those who are fully vaccinated have received booster doses. As far as the efficacy of the vaccine, the CDC is reporting that in December 2021, the risk that unvaccinated adults aged 18 and older had of testing positive for COVID-19 was 2.4%. Or I'm sorry, was 2.4 times higher than those that were vaccinated. And in January, 2.6% higher than those that were vaccinated. And the risk of those unvaccinated individuals of dying from COVID-19 was 14 times higher in December than those that had been vaccinated. The figures on the risk of dying for January have not yet been published. However, the CDC also does have the risks for the unvaccinated aged 18 and older versus vaccinated individuals that had also been boosted. And the risk that unvaccinated individuals had of testing positive for COVID-19 was 3.2 times the risk that the vaccinated and boosted individuals had. And the risk of the unvaccinated in December of dying from COVID-19 was 41 times the risk that those had been vaccinated and boosted had. So I think those are some compelling figures there. Unfortunately, our demand for vaccination has declined significantly, with only about 3,300 doses administered in the last week. And that's down from almost 15,000 doses that were administered the first week of December 2021. That was soon after the Omicron strain had been announced, and we had people that were very actively seeking boosters or getting their vaccination series if they hadn't already. Washoe County Health District has administered about 8% of all the vaccinations that have been administered over the past 4 weeks. Demand at our community pods is declining. We administered 68 doses at the Convention Center pod last Thursday and 46 doses at our Spanish Springs Library pod yesterday. Demand for testing is also way down. We tested only 31 individuals at the Livestock Event Center testing location on Monday and just 38 yesterday. So we're currently maintaining staffing for now, but we're anticipating reducing our staffing further if the testing demand remains low. The state launched a COVID-19 treatment webpage on their Nevada Health Response website yesterday. That's the nvhealthresponse.nv.gov site. The treatment clinic and home administration services are being provided here in Washoe County by the Northern Nevada COVID Treatment Center, and that's funded through the state ARPA funds. The state has also launched a call center to assist people in accessing treatment. That phone number is 800-401-0946. And there's also a pre-screening tool that can be accessed through the website. Treatments include the antiviral pills, Paxlovid and Molnupiravir, and the monoclonal antibody Sotrovimab treatment. The home tests are now readily available through the federal government website and a number of organizations that are distributing free test kits that were purchased by the state and through local pharmacies. And with vaccinations and home testing both readily available and treatment now becoming more accessible, we are messaging these priorities. 1, get vaccinated and boosted when eligible. 2, get at-home test kits and have them on hand to use if symptomatic or as needed for gatherings. And 3, isolate appropriately and explore treatment options if you test positive. Treatment is currently limited to those at high risk of developing serious symptoms of COVID-19 due to the limited supply, but is anticipated to become more readily available as supply increases. I have not read pandemic response plans from numerous countries, but I have read our county pandemic flu response plan and the federal response plan. And both of those included non-pharmaceutical interventions, things like lockdowns, limiting mobility, those types of things that were just commented on as lies. So I know that those were in that plan. And I am not a medical doctor. I do not practice medicine. I am the public health official. So that I'll close my remarks here. And we have Dr. Danko. I believe she may have some additional comments for update on COVID-19.
Thank you, Kevin, for that summary. Really well said. And we continue to applaud the efforts of the health department and the health district on trying to get the best, most accurate information out there that we can. I think it's nice to have the opportunity to reinforce some of these things in clinical practice. And it is certainly great news about our improving trends with 7-day average and new cases, though I will be cautiously optimistic because COVID has certainly thrown us more than one surprise along this 2+ years here. So we do still have a fair amount of COVID cases in the hospital. The severe illness that we see in the hospital is much worse than prior flu seasons. I can attest to that as having worked prior flu seasons in the hospital. And certainly is more taxing on the patients as well as on the resources in the community and in the hospitals. And I will say that still predominantly we have unvaccinated patients struggling with COVID and with severe illness in the hospital. And as we see community trends improve, I've said before, we tend to see those trends improve much slower in the hospital because patients who get severe COVID infection often struggle with that illness for quite some time, sometimes to the effect of weeks and sometimes even months. So we still do see high volumes in the hospital. Not everybody has active COVID infection, but one of the things that I'll highlight here is that we are seeing an increase in the complications that come from prior COVID infection And that includes patients that have already recovered from COVID infection, sometimes even months before, and sometimes even in patients who didn't require hospitalization for COVID infection. And we're seeing a tremendous amount of inflammatory conditions that are arising, lots of cardiovascular problems, such as the heart not pumping as efficiently and as well as a healthy heart. We're seeing lots of residual lung problems with people having difficulties in continuing with their exercise tolerance or getting back to the baseline that they had before infection. And we're seeing lots of blood clotting problems in people that didn't experience blood clotting before. And that can include blood clots in the legs, blood clots in the lungs, which actually can have severe complications to both the heart and the lungs. And we're also seeing increase in strokes. So really it's not to be underestimated that COVID is not just like the flu. It does cause significant total body inflammation. And oftentimes those inflammatory conditions can wreak havoc even later on, even after mild or moderate infection. So you don't have to have bad disease or be hospitalized with COVID to experience very bad complications and long-lasting complications. So really that directly goes back to Kevin's comments about continuing to be cautious, continuing those prevention mechanisms that we know work for COVID and for other illness mechanisms as well, and continuing to promote vaccination, because we know that those who are vaccinated experience far less severe COVID infection and also far less of these complications that come after COVID recovery. That's about all I have, but happy to take any questions.
Thank you, Dr. Danko. Thank you, District Health Officer, for all you guys' hard work. We're almost there, but we're not quite there. So appreciate all the information and data. Appreciate the team across the District Health. We're not taking public comment on this item as this is a presentation. Any questions from the board for either the District Health Officer or Dr. Danko?
Chair, this is Councilman Dare.
Yeah.
I did have one. I've noticed, and I just wanted to ask on the lingering cough that I've seen in many of dear friends that have gotten this. What is that, and how are we seeing a lot of that? Is that part of what you're sharing? I mean, I'm starting to see people who they just from not sleeping at night because of the cough just getting worse. Is that part of this, or is that like personal complications that we're seeing?
I think from a medical side, that can be very individualized. Some people do not experience the lingering cough. In fact, some patients don't even have the cough or necessarily in the upper respiratory tract type symptoms with COVID. Some have more GI symptoms, such as nausea, vomiting. Some have more even higher up, such as sinus type infectious symptoms with sore throat. But as far as lingering cough goes, I think it depends on a couple of things. One might be the underlying condition of the lungs. Are there previous existing conditions, such as exposure to substances such as asbestos, or potentially conditions such as emphysema, or other underlying lung conditions that make it even more impactful if COVID does impact the lungs? I can also say that sometimes it just happens to be how severely the COVID infection gets into the lungs and infiltrates the lungs. And sometimes it can be certainly a reactive process or an inflammatory process that does take quite a long time to get better. And some people, even without the cough, don't quite get back to their regular, what I would call exercise tolerance, being able to go to the grocery store or walk around or go back to their fitness routine quite yet, even after quite some time.
Thank you.
I had a question for Kevin. Quickly here, I might have missed this, Kevin, but Paxlovid, are there supplies of that now?
Yes, thank you, Dr. Klecking. There are supplies of Paxlovid. They're still quite limited in what's being allocated federally. The state gets an allocation that the Board of Pharmacy then distributes. So we do have Paxlovid that comes to Washoe County. It's available. It's available through that new Northern Nevada treatment center that I mentioned. And we're hopeful that we'll see that increasing soon, that allocation, and it'll become more readily available. That's why at this point it's only available to those that are at highest risk for severe disease. But as more becomes available, it should be available more broadly for the community.
But they haven't given you any indication when that would be happening?
It's going to be somewhere between now and August when we're supposed to have ample supply. I expect we're going to see just an increase, but I can keep the board apprised on what we're seeing on those numbers moving forward.
Right. One other comment I just wanted to make is in regards to the recent data coming out now too, that's showing behavioral health is being affected by COVID longer term. So these ones that are the ones that are having the problems with the what I want to call it, lingering on. I can't think of the term I want to use, but many months after they've been over the COVID, they still have behavioral health problems. So very interesting data.
Great point.
Yes, I think if I might add into that, sorry, Oscar, to interrupt you, but I think really interesting points, and thanks for highlighting that. I very much agree. There's lots of behavioral health problems, and we're certainly seeing a rise in data with substance use disorders as well as it relates, I think, overall to the pandemic and sometimes related to COVID as well. And I think that it's important to highlight as we do talk about new treatment medications that we're very excited to have those in order to prevent and hope to prevent severe disease and hospitalization. But to once again just highlight that just even a little bit of prevention is so much better than trying to fight COVID on the back end. And again, even people where we can prevent severe infection and hospitalization can certainly be at risk for those severe and long-lasting complications with the lungs and total body inflammation, and as we just heard, even with the behavioral health complications. So really our preventative measures and vaccination and continuing with hand hygiene and prevention measures are certainly not mandated, but definitely still worth giving a thought to.
Great comments from the board. Thank you for those questions. Any additional questions from the board? Seeing none, we'll close item 7. We'll move on to item 8, consent items. Any items that would like to be pulled by the board? Seeing no hands. Any public comment in relation to the consent items? Susie.
I don't have any registered public comments, and I don't see any hands raised.
Okay. So can I please get a motion for consent items, items 8?
So moved. Novak.
A motion
Second, Rika.
a second for Dr. Novak. All in favor?
Aye. Aye.
Aye.
Motion carries unanimously. Thank you very much. Move on to item number 9. Presentation of the Employee Recognition Committee. District Health Officer, do we have?
Yes, thank you, Chair. We have Kelsey Atkin is going to do the presentation on our employee recognition program, and she's been leading the committee that's developed this for the health district.
Great. Welcome, Kelsey.
Thank you. So let me share my screen if I can. Okay. I'm gonna screen share. And okay. I'm sharing it, but only on my end. Okay. All right.
Yeah, we can see it now.
Perfect. Can you also hear me?
Yes, we can.
Okay. So similar to the recently announced Washoe Star Awards that Washoe County Human Resources recently rolled out, Washoe County Health District has also been working on putting together a employee appreciation and recognition program since the Shining Stars program was phased out. And together with a committee that included representatives from each of the division, we actually came up with a program that is very similar to the one that Washoe County created for that Washoe Stars program, which is a bit of kismet. But to walk you through the new program, we had a naming contest and everyone at the Washoe County Health District was invited to participate. We wanted to have the employees name the new program to hopefully increase buy-in and make it really feel like it was theirs. And the winning name for the program was Health Heroes Awards. And the key components of this new program, when we were designing it, we wanted it to be a very equitable program. And what that meant is, in the past, there were some concerns that if it was just based on customer service and it was just based on Washoe County Health District customers nominating employees for recognition, employees within the health district that didn't have public-facing positions, it was harder for them to get recognition. And for employees that maybe had a public-facing position but were unfortunately maybe in a less positive public interaction, such as something along the lines of fines or anything like that, versus, immunizations or family planning, they might have also not as equitable of a chance of recognition. So we really wanted to build a program that gave everyone a fair shake. But we still wanted to retain that customer service aspect that the Shining Stars program had. We also really wanted this new program to be centered around the Washoe County Health District culture and values. And we wanted it to be meaningful for the employees. So what we came up with is a two-tiered program, an internal recognition and an external recognition. So externally, this is the customer service aspect of the program. This is where customers can nominate employees, and we're building that nomination form into the existing customer service survey. And for the internal recognition, anyone within the health district can nominate anyone else. So it's multi-directional. It's not top down. It's not just unilaterally. And nominations here will be submitted through a link on SharePoint, similar to how there's a Washoe Stars link now on the Washoe County Inside Washoe homepage. For both of them, the recognitions are going to be based on one of three or multiple, people can select more than one, of the three Washoe County Health District values. And we did three because we kind of combined partnership and collaboration. And so when anyone, whether it's a customer or an employee, nominates someone, they're prompted to select which one of these values was this employee exemplifying. And then they also need to include an explanation of why they felt that employee is an exemplary model of that value. So here is an earlier example of one of the submission forms where you can see that they're prompted to select at least one of those core values. And we also thought it would be helpful, especially for the public, to get some brief definitions of those values and examples of what those values might look like. And then also we need an explanation of why. From there, all of these submissions, both internal and external, will be funneled to one designated person on the committee. And once a month, the committee will meet to review all of the submissions. The person that the submissions are getting funneled to will scrub all the submissions of personal identifiers and present them to the committee. The committee will then vote on which nominations hold enough weight to move on to a full value recognition, which includes a District Board of Health mention and an invitation to a quarterly recognition breakfast or luncheon. The submissions that don't move forward for full value recognition based on committee votes are still going to receive an honorable mention, just because even if it doesn't hold enough weight for full value recognition, someone still took the time to nominate that employee and they deserve mentioning. At the quarterly recognition breakfast or luncheon, winners are pooled based on which of the values they received recognition for. And one name from each pool will be drawn, and the winner is going to be given their choice of a prize. So prizes might include gift cards, Washoe County Health District swag. Someone cannot win twice though. They can be entered in more than one value, but if they win one, they can't win twice. And once we launch, we are currently working on getting the tech side of it up and running, working with Rihanna on the customer service survey, getting that plugged in, and then also getting a link created on the Washoe County Health District SharePoint. And then once it launches true to public health, it will be subject to evaluation in terms of what's working, what's not. Do we truly need monthly meetings based on volume and things like that? So what you see here within 6 months from now, a year from now, the program might evolve, but that's basically it. Does anyone have any questions?
Chair, if I might add, I just wanted, again, thanks, Ms. Atkin, for leading the committee and the staff that volunteered their time to develop this. We did have the Shining Star program that the county had previously. That had gone away, but that program didn't have much structure to it. And so I think this is a step forward for the health district to have our own recognition program based on our values. And I look forward to bringing the individuals to the board meetings for the board to recognize for their performance at the health district.
Great, thank you. Any comments from the board?
Yes, sir.
Yes.
I just want to say, I do think this is really important, as we come out of this COVID time, and everyone's been working so hard, a lot of different things going on. I like the idea that we pause and thank people for what they've done and give everyone a chance to kind of step back in and look at some goals and go after some things. And so I love that. And I think it'd be fun. I don't know. I'm wondering if you can get something better than a little trophy you give. What are you going to give somebody there? But if they get this, what's the special prize, Kevin?
Oh, we're looking at gift cards, but we'll take the key to the city of Sparks.
That's what I was wondering. I was thinking we could do something real special. I just think we want to make it cool. I think it's a neat thing. Thank you.
Thank you.
Yes. Someone say something? Sorry. No, thank you, Kelsey. I think it's to Councilman Dare's opinion. I think it's great for all the reasons he has stated. I think it sounds like he has put a lot of thought and process into it. And so I think it's amazing. It holds a lot of value. And just my question is, what's it take to get invited to a breakfast? That's what I want to know.
Personal invitation? I feel like you're always welcome.
Awesome. That's what I love. Thank you. Great work. Great work. It does not look like there's an action item associated with this. So thank you for the presentation, Kelsey. We look forward to those being recognized that come to our board meetings. We'll close item 9 and we'll move on to item 10, Interhospital Coordinating Council. Looks like we have Jesse with us.
Thank you, Chair Delgado and members of the board. For the record, my name is Jessie Latshaw. I'm the Public Health Emergency Response Coordinator for Washoe County Health District. And today I am introducing Brian Taylor, our IHCC Chair, or the Interhospital Coordinating Council, and I'm in charge of that as well. Brian, go ahead.
Good afternoon, everybody. Let me share my screen here. Let's see. There we go. Can everybody see that?
Yes.
Yes. Great. And can you hear me?
We can hear you.
Yes. Excellent.
Yes.
Excellent. So good afternoon to the board members, Chair Delgado, Vice Chair Lucy, and District Health Officer Kevin Dick. Again, my name is Brian Taylor. I'm the Emergency Manager for REMSA and the current chair of the Interhospital Coordinating Council, or IHCC. It's my honor today to present to you the accomplishments of your healthcare coalition, or the IHCC, for 2021. First, I'd like to tell you a little bit about our healthcare coalition. It's a little different than other coalitions nationally and even in this state, because IHCC reflects our local healthcare community. We have outpatient facilities, critical care facilities or hospitals, long-term care facilities, community partners, local health departments, local government, physicians, emergency management agencies, health centers, home health agencies, emergency medical services, and behavioral and mental health centers and agencies all working together. In 2021, everyone on this board and everyone in our entire community spent a lot of time working hard to deal with the COVID-19 pandemic, and so has IHCC. But many other issues face our local healthcare community as well. So the IHCC has been working very hard on planning, exercising, mitigating, and responding to incidents and potential incidents that may affect our healthcare community locally. Here is a list of 9 accomplishments in 2021 that we felt noteworthy to bring to your attention. The COVID-19 grant PPE purchases and distribution, burn care and mass casualty course and exercise, emergent evacuation workshops and exercises, evacuation med sled training and purchases of these med sleds, NDMS exercise, alternate care site plan update, coalition members and resource and gaps analysis provider plan updates, HAZWOPER training, and we were very active in the state's crisis standard of care updates. COVID-19 grant and PPE distribution. We worked to distribute over 220,000 surgical masks, over 661,000 isolation gowns, more than 29,000 N95 masks, and 26 fit test kits to go with those so that everyone could be fit tested appropriately. Within this last year, this was a really exciting thing that we did. We had an interactive training about burn care and mass casualty in a burn setting with specialists from the University of Utah, the industry leader on the West Coast, Health Care Burn Center, and the Utah Department of Health. We had over 100 participants. It was both in person a little bit and mostly on Zoom. So we had 40 organizations across the state, all throughout Northern Nevada, but also Central and Southern Nevada involved. Course and tabletop exercise all occurred within one day. And this program was so well conducted and so well interacted with that the University of Utah has placed this as an example on their website, and it's still there today where people can tune in and see what we did and learn from those achievements or those from that exercise. We also conducted an emergent evacuation workshop. Locally, we have a really, really good nationally recognized plan for hospital evacuation. The only small shortcoming with that plan is that we recognize we didn't have a great emergent evacuation. So 90% of evacuations are what we call urgent and non-emergent. So like power outages, some structural damage, things like that. But these this emergent plan was recognized as something that we needed to improve upon, like fires, something that is extremely, impactful to the medical facilities. So we conducted, in order to put this together like we normally do and only according to what we need in our community, we conducted a 3-day workshop. We provided lessons learned from other hospitals across the nation, listed some on this slide. We conducted a tabletop exercise, and there will be an implementation of the best practices in this soon-to-be updated plan that will be taking effect in 2022 and will come before your board as well. We also had a collaboration with the VA or the Veterans Hospital locally for an active shooter exercise, and also a national disaster medical systems interaction where the VAs across the nation have a system where if an area is impacted by a disaster such as a hurricane, tornado, and they need to relocate their patients, we in this region are part of the ENDMS system as a receiving location for those patients. We did a tabletop exercise, as you can see pictures of here, where we decided that if they had to bring patients in on C-130s or other aircraft, how we would distribute them throughout our community. And we do have a plan for that, and we interact with the federal government in that capacity. Again, we talked about that evacuation training. We did recognize the need for what is called med sleds. Now, these med sleds are very important for being able to take patients down multiple flights of stairs in a multi-story medical facility, also in schools. So we conducted, we had a train the trainer course. We purchased 154 evacuation sleds, 14 partners from hospitals, fire departments, Reno Sparks Tribal Health, RIMSA, and Washoe County School Districts were involved in this training, and they are distributed throughout the community so that they can be brought to bear if we do have a situation where they're needed to be used. There was also a HAZWOPER training, so you may ask, what is HAZWOPER? HAZWOPER is a 3-day intensive class on how to deal with and decontaminate patients that may show up at your facility that are contaminated with hazardous materials or sea-burning items. We funded this 3-day training, which included Renown Health, Northern Nevada Medical Center, St. Mary's, and the VA, where they learn how, if they have people showing up to their facility that are contaminated, how to treat them, how to take care of them, and how to decontaminate them at their facility, which all the critical care facilities locally have capacity to do. Here's a list of about 19 trainings and meetings conducted in 2021, many of which are reoccurring, both quarterly and even monthly. So this is, we stay pretty busy with all of this. Now, you may ask how we determine how to focus our efforts. Well, we poll all our members to create a hazards and vulnerability assessment, or HVA, to help guide us through this process. This community is very unique, as you guys know, and we need to create plans that are unique. One size fits one, not one size fits all. So if you take a look at the polling of our different agencies and our different participants in the IHCC, you can see our 1 through 10 things that we focus our efforts on. Obviously, infectious disease outbreak is number 1 with the pandemic currently at hand. Also earthquake, severe storms, internal fire, and others down here in this list. On the left side is Washoe County's 13 regional hazards. So they do correspond quite a bit, but there are some things unique that we concentrate on within our coalition. So these are some of the anticipated activities in 2022. These activities relate directly to those HVAs that we talked about and what our members feel is important to our health community. Again, a unique healthcare community, and that is what we live in, both in our entirety of our community, but our healthcare community as well. Our IHCC works because our members are committed to making it work and its success. I'm very passionate about that. I've been a member of IHCC since its inception, and this is the second time that I've been elected to the chair position. We always begin our monthly meetings by saying this is kind of a joke amongst us, but this is not the meeting that you have to attend. This is the meeting that you want to attend. Every member of our coalition stands ready to help each other with any issue we have individually or together collectively. That's been proven time and time again, from sharing PPE and working out solutions through the pandemic to collaborating with multiple agencies to address the massive wildfires that affected our community. We break through those political, financial, and even competitive barriers to help each other, thereby creating a stronger healthcare community through this collaboration. And I thank you guys for supporting us thus far, and I hope you will continue in the future. But I just want to let you guys know that I have worked in EMS over 39 years in this community, and this is one of the most effective coalitions that I have ever been a part of. I'm in this community. We're very effective, and we are very proud to serve the Washoe County community. Thank you.
Thank you, Chairman. Any questions from the board?
I do.
Councilman.
Yes, thank you for that. And I think I've always been amazed since I've been in office of the coordinating that we do and the training, and it's always fun to even be a part of them sometimes. My question kind of goes on something you didn't hit on. I don't know if this is even part of your area, but I'd love to hear how we've seen in these last 2 years, obviously, how important it was that our hospitals work together. Sometimes it went well, sometimes I don't think it went well. So being honest with you, what do we learn? What can we do? And are you guys doing a special approach to that? I mean, when we have people, large amounts of people sitting in hallways waiting to get in, I have questions, and these are things that I don't have answers to. I don't even have arms long enough to make a difference to. All I can do is sit over here and say, oh, what can we do? But it sounds like you're closer to that. Is that part of what you do or not part of what you guys do? And if so, do you have any ideas? Because this is a huge concern for me, for any of us, I think. It's not just me, for all of us, that we just want to make sure that we're doing that. And I'm sure it's a concern for you. So I just want to give you, do you mind speaking to that? I appreciate all the things we accomplished. I don't want to set those aside and say they don't matter, because they're wonderful. But this during this time, it was very disheartening at times to know what was happening there.
This is Jessie for the record. That is an EMS transport / hospital piece, so it's kind of complicated. The Healthcare Coalition is really on that preparedness for emergencies, maybe not necessarily the EMS transport waiting time. That is different meetings that can go on with the EMS coordinator role. I think that it is something we've all discussed in how can we improve, but really our coalition focus is that emergency response to a hazard in our area, and then working on those plans and how to improve that particular scenario. Not to say that we couldn't talk about those, but that's not part of what the coalition has historically done. If that answers your question.
It does a little bit. And, and I thought maybe so, because I've seen everything's come. Your name says something different. Your name says intra-hospital. So I'm all, hey, if we're intra-hospitaling it, this matters. And so it's all good if that's not your focus. And obviously we're not trying to step on people's toes, but maybe actually I would ask that maybe you do need to look into it, even if it's just to give some other eyes. You guys obviously have proven you know how to pull things together. I mean, we've seen this for years, and it's not insulting to anybody. These are big problems, and maybe having some more hearts and minds on it would be good. But it is a concern that, again, the hardest part about sometimes being a city councilman is we don't get to really get involved. We get to let everyone else do it, but it's been a little frustrating watching that. Thanks.
Yeah, agreed.
I would just add in there that I believe that you're going to see a presentation later on in the meeting here where being part of REMS, I kind of know a little bit about what they're going to be talking about, and it does pertain to your questions. So I think that maybe that'll be an opportunity to shed a little more light on that. Thank you very much for your comment or your question.
Thank you. Any further questions from the board? Seeing none, thank you again for all the hard work. It's always important that we don't work in our silos and we're all working together, especially for the safety of our community. So it's been great that you guys are able to keep those meetings happening and going, and always continuing to do examples and run scenarios. We always got to stay on our toes. So appreciate you guys very, very much. I know it's complicated, but thank you. We'll close item 10 if there's no further questions. We'll move on to item 11, presentation presentation and possible acceptance of the workforce development plan. This one's up for action. Before we kick it off, Susie, are there any public comments with item 11?
I don't have any registered public comment, and I don't see any hands raised.
Okay. So we'll close the public comment for item 11. We'll move on to presentation. Rayona, you're up.
Good afternoon, members of the board. Can everybody see my slide deck in front of you?
Yes.
Okay, wonderful. Rayona Lavoie for the record. Today I'm going to be giving you a presentation on the I'm going to be giving you a presentation on the Washoe County Health District's Workforce Development Plan. I'm going to start by giving you the 50,000-foot view of why there's a substantial amount of energy around modernizing the public health system, and then I'll talk more about how this relates within the how this relates within the health district in a few slides. I'll use the COVID-19 pandemic for our example because it exposed many opportunities for improvement within the public health system that many of you have heard about. On one side of the pandemic, we could talk about the factors that disproportionately affected certain population, causing higher transmission in some communities, which required us to create messaging and place resources into these communities. And we can also speak to the factors that affected individuals who were infected or exposed that were also unhoused or needing a different option to quarantine because their living situation didn't afford them the opportunity to safely quarantine. Public health was around the table to problem solve and to collaborate to create solutions by working with partners in the community. We can also talk about another side of the pandemic where we needed to create a reasonable and modern software system to allow us to translate and share data in real time and across entities to support cases infected with COVID-19 and to reduce the spread of the disease. COVID is the perfect example that compounded multiple challenges on different levels that required public health professionals and stakeholders across the community to work together to act quickly to solve complex challenges. To address these challenges, public health modernization is about building the public health workforce by ensuring that we have the right processes, policies, and people in place to help us solve complex problems so that we're prepared to respond to public health challenges in the future, like another pandemic, obesity, mental health challenges, substance abuse, and clean air. Bringing it a little closer to home, maintaining the health district's accreditation status is one effort that we can think about how we're modernizing public health. The Public Health Accreditation Board seeks to advance and transform public health practice by championing performance improvement, strong infrastructure, and innovation. We get to carry these efforts out by maintaining and operationalizing what we like to call our six-pack. So this is our strategic plan, our workforce development plan, our quality improvement plan, the community health needs assessment, our CHIP, as well as the health district's communications plan. To speak directly to workforce development, Standard 8 that you see in front of you ensures that the health district maintains a competent public health workforce. These requirements are what we have to include, such as completing various assessments to identify gaps every 2 years. Organizational capacity is one of the health district's strategic priorities. This slide is in here because it's important to note that the goals and objectives that are included in the workforce development plan were pulled from the strategic plan and they're directly aligned. So let me tell you a little bit more about the process so you can see how the two initiatives work hand in hand. With COVID, many initiatives that are required by FAB to maintain were held off so that we could focus our attention on our response efforts. So while we were mapping out how we were going to tackle the important work that goes into the strategic plan, the workforce development plan, and our performance management system, we also recognized that these projects were time intensive, not only for us, but also for divisions, because we needed to gather input from the subject matter experts, which are our staff. So we jumped at the opportunity to braid the planning process together to complete the workforce development assessments, the strategic plan, as well as efforts related to ClearPoint, the health district's performance management system. So we braided the projects together, which gave us the ability to look at the initiatives side by side to discuss the strategic goals of the organization and the needs of the workforce to help get us there. And of course, these two initiatives led us to creating measurable and realistic outcomes to track our progress. So to develop the workforce development plan, a bulk of the information came from discussions during mini strategic planning retreats with each division and from interviews with board members. We also conducted a workforce development survey to gather staff's perceptions of their skill levels against the core competencies for public health. The core competencies for public health professionals are organized into 8 domains representing skill areas within public health. So these are things like data analytics, communication skills, health equity skills, community partnerships, things of that nature. Last but not least, we also reviewed literature to better understand the emerging trends affecting public health. One that is likely not new to you, that was a constant discussion point across the planning process, is how to approach the challenges caused by the Great Resignation. These challenges include workers who are leaving for better paying jobs that expose them to less COVID-19, or they might be leaving to find positions that allow them more flexibility, like working from home. Additionally, the demand for workers is also allowing for increased mobility in the labor market. On top of these challenges, the shortage in public health workers and the burnout is a real thing that hits close to home as staff continues to respond to the needs of the pandemic while also being fatigued almost 2 years in. After the assessment and input was gathered from all of those involved, 6 focus areas rose to the top. We also identified different delivery methods to meet staff where they're at and to provide different learning experiences. So this is anything from on-demand trainings that staff can find through public health resources, online, that move at their own pace, or this could be a lunch and learn that allows for group discussions. These are just 2 examples, but we have 5 different delivery tools that we'll be implementing with the workforce development plan. Traditionally, our workforce development plan mainly focused on core competency trainings, but as you'll see in the next few slides, we tailored our approach to meet the realities of today and to prepare us for the future of public health. So I'm going to start with our onboarding, and then I'll start going through each of our focus areas. But for onboarding, we'll continue to provide 2 orientations, one hosted on the employee's first day, and this is really to learn about mandatory policies and trainings. And we'll continue to provide a quarterly orientation to give staff an overview about each division. Following the health district's orientation, the county also has an orientation where staff will learn more about the policies, trainings, and the county's mission. We're also going to build out additional onboarding activities focused on acclimating employees to their role, the health district's goals, as well as what our organization has to offer. The second focus area is core competencies. We'll continue to provide trainings that were needed as identified in the workforce development survey, and we're also going to include trainings that leadership identified for their programs. Our third focus area is diversity, equity, and inclusion. This area is new. With FAB's renewed standards, there's a lot of work required from the organization to ensure that our policies, procedures, and practices are being implemented or are created with a health equity lens. So we recently received a health disparities grant from the CDC, which will help us get the work started, but this focus area will include a series of trainings and an organizational assessment that you'll hear more about at a later date. Our fourth focus area is supervision and management. So we have a focus on our supervisors and our management staff within the organization. We've had several staff be promoted to new supervisors. So there's some many initiatives that we're putting into place to ensure that our leadership team has the right tools and support that they need to succeed. At the moment, staff in a supervisory role are completing the county's management development series, along with other supervisors from different areas throughout the county. Cohorts were created and they're meeting over the next 6 months to complete 6 classes that are online. And then each topic has a practical application portion that is live. In addition to our partnership with the county HR, we're also focused on building out additional efforts around other activities for peer groups and facilitated discussions on coaching and mentoring. Our 5th focus area is leadership development. When we conducted the workforce development survey, we asked a few questions about tenure at the health district and learned that about 60% of staff have worked in their current position for 5 years or less. So this tells us that there's been a lot of movement into new roles, or they might be new to the organization. So a lot will go into this focus area. The county is creating a leadership program similar to UNR's Advanced Leadership Academy. Some of our staff have completed the academy and we've received great feedback. So we're looking forward to them rolling that out. We'll also be creating activities to make sure that staff have professional development opportunities within reach to take advantage of. Last, we have resiliency and wellness. In the workforce development survey, we added a section to better understand the mental health impacts among staff during the period of time the organization was responding to the pandemic. Over 2/3 of staff reported the pandemic impacted their mental health. Of those who experienced an impact to their mental health, only 50% of staff received the resources needed to cope with the concerns about their mental health. A few months before we gathered this data, a national survey assessing the mental health impact of the pandemic on healthcare workers also highlighted similar trends that I just spoke about. So with that, we're still in the preliminary stages of identifying wellness strategies and resiliency programs, because we know that this is very important. Our staff need it, and we want to make sure that we're meeting staff where they need us to, and it's just as important as their physical health, so that we're ensuring that they're showing up with their best and their healthiest self. So let's talk about next steps. The work plan is being created as we speak. Again, everything in the work plan will directly support the goals and objectives within the strategic plan. So you'll hear more about these activities through the scorecards and when we provide updates about the strategic plan. And with that, I'll take any questions that you might have.
Great presentation, Riona. Looking at the board for any questions. Any comments? No? So it's a lot of work you put in there. Thank you so much. It's great opportunities for leadership. I really like the last piece. Such a young organization, a lot of changes. Even today, seeing how many hires we had today, I don't think we've had that many in quite some time. So great opportunities for inner growth as well. So thank you, Riona.
Thank you.
Seeing no other comments, a motion, please.
I move to approve and accept.
A motion.
I'll second.
Second. All in favor?
Aye.
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 Opposed, motion carries unanimously. Thank you. We're moving on to item 12. I believe this was a request also, but this is item 12, presentation regarding Washoe County Health District and Community Behavioral Health Initiatives. We have Julia Ratty presenting.
Thank you, Chair, for the opportunity, and thank you, Councilman Dare, for the request. I'm here today to respond to that request and provide an update on the behavioral health initiatives here at the county. I'm going to go ahead and share screen. Hopefully you're seeing my screen.
We see it.
Fantastic. So for the record, my name is Julia Ratty, Director of Programs and Projects. So first I want to just take a minute and talk about the health district's role when it comes to behavioral health. Just to note that there is really no federal, state, or county law or ordinance that specifically identifies a role or requirements for the health district. As you know, a lot of the work that we do in the health district is based on law or ordinance. In this case, there's no such guiding oversight. And so therefore, our health district efforts in this area have been pursued primarily based on where there's been an identified community need, or occasionally based on the fact that there's been some grant funding available for us to pursue. You all know that one of the big things that we do here at the health district as part of our role in the community is to do a community health needs assessment. The last needs assessment was completed in 2018. And as part of that process, our wonderful team in EPHP, working with the community, takes a deep dive into data and then facilitates a community process where priorities are set. In the last round, you can see where the two blue arrows are, mental health ranked number 2 and substance abuse ranked number 7. And we tend to think of mental health and substance use as behavioral health priorities. And so you can see they ranked relatively high in our last community health needs assessment. That led to our community health improvement planning process. So again, this is not the health district's plan. Our plan would be our strategic plan, but this is the community's plan on what the community wants to address. And the 3 things that rose to the top in that plan, as you I'm sure recall, is housing, behavioral health, and physical activity and nutrition. And so then again, because it rose as a priority for the community, that is another good indicator for the health district to lean into this space. We did do an extension of the 2018-2020 CHIP into 2021 and extended our efforts in behavioral health while we were waiting to kick off the current community health needs assessment and planning process. I'm not going to go over all of the behavioral health initiatives that are in that community plan, but if you'd like a refresher, the link to the community health improvement plan is in this presentation, and the initiatives that the community has prioritized are on pages 29 to 50. So as part of the community health improvement plan, the board, through the district health officer, approves some funding to make sure that we don't just convene the community and ask what the priorities are, but that we're also able to move forward on some of those initiatives. There were 5 behavioral health initiatives identified as part of the CHIP initiatives, and these are areas where the health district invests some funding to make sure that we make some progress. I think many of you are aware that we have a crisis when it comes to child and adolescent behavioral health, and so several of the projects are focused in that area. The Children's Cabinet, in partnership with Quest Counseling, are implementing what's known as a knowledge campaign, really focusing on suicidal ideation in youth. Quest Counseling is also working with a parent education piece that they received some funding for. We also provided some funding to Eddie House. I'm sure many of you are familiar with Eddie House. Is an organization targeting unhoused youth, specifically so that they could hire a mental health professional to provide some trauma-informed counseling to the clients of Eddie House. Workforce is a significant issue when it comes to behavioral health, and there's growing research that shows that the peers, people with lived experience in either behavioral health crises or behavioral health diagnoses or substance use, who are then trained, can be a really valuable part of our workforce. They're called peer recovery support specialists. And so through this grant, we provided funding directly to CASAT that helped to pay for the training for some of these folks who have lived experience to be able to get their peer recovery support specialist certification. And then finally, we did a significant grant to social entrepreneurs to facilitate a community planning process about around the improvement of our behavioral health crisis response system. I'm going to dive into that one a little bit more deeply at the end of this presentation. So we'll just leave that one there. But those are the five initiatives that are in the CHIP that we then also, as the health district, provided some additional support to. Here, I should have said this at the beginning, but I just want to emphasize, I get the privilege and pleasure of being the presenter for all this information, but I am really speaking on behalf of a lot of different people's work. This is work across the community, across the health district. And so just want to recognize that lots of good work by lots of good people. So because behavioral health, or because of the identified need, how it presented in the community health needs assessment, how it presented in the community health improvement plan. Then behavioral health also made it into the Washoe County Health District strategic plan that you recently approved. And so most of the work that we do in the behavioral health space falls under the impactful partnerships priority. And I think that, again, is an indicator, this is not a space that we necessarily own as the health district, but it is a space where we can be a good community partner, a leader, and partner with others. And so there were two specific goals, outcomes, and initiatives that landed in the strategic plan. One was that work on the improved behavioral health crisis response system. And the second was some wonderful community work that is happening to address the alarmingly high rate we have for suicide among seniors in Washoe County, and specifically focusing on the issue of seniors who are experiencing loneliness and isolation. Highlighting that initiative a little bit more, that initiative is known as the Hello Project. It is a Robert Wood Johnson grant funded initiative. The partners include the Food Bank of Northern Nevada, Renown, the state of Nevada, and many others. This project kicked off right at the beginning of the pandemic, and so much of it did shift to virtual. In the last year of this project, they have shifted to refocusing on the 89512 zip code, doing healthcare provider education, helping seniors with navigators to navigate the system, doing some community organizing in 89512 to get neighbors and families involved, and then having a good data portal on the Truckee Meadows Tomorrow site. Joe Dibble, who is a health educator here at the Health District, is our key representative on this project as we move into the final year of this significant community effort and community grant. Another project I wanted to remind you of, initiative that I wanted to remind you of, because it's been a while since we've talked about this, is the Nevada Resiliency Project. This is, I think, an unprecedented disaster response focused on behavioral health. This has been funded primarily through some of the extra funding that's been coming into the state around the emergency response to the pandemic, specific to behavioral health. It's a partnership with the Washoe County Human Services Agency and the state of Nevada. And so what we've been doing is, since August of 2020, every individual who receives a COVID positive test, not the home tests, but a PCR test, and is going through the contact tracing disease investigation process, also receives a wellness check-in call from a resilience ambassador who's been trained with psychological first aid skills. And just to give you a snapshot of the last 6 months, so looking at the second half of 2021, that involved 9,909 encounters. And those encounters are defined as a conversation of 10 minutes or more. So wellness or a resilience ambassador calls, they get someone and they talk to them for at least 10 minutes. They can help with psychological first aid, identifying somebody who's really in crisis. They can also just help with connections to resources in the community. But at that moment that you're hearing this challenging news, somebody's calling to check in on you. And again, the fact that we've been doing this since August 2020, now there have been times during the surge where not everybody has received a call when the numbers grew to be unmanageable. But for the most part, since August 2020, these resilience ambassadors have been making these follow-up phone calls to every COVID-19 positive diagnosis. Another significant initiative that is in the Community Health Improvement Plan and is getting some attention here at the Health District is known as Zero Suicide. Zero Suicide is based on this foundational belief that some good research was done that showed that many of the individuals who had attempted or been successful in committing suicide had very recently been in contact with their healthcare provider. And that if we did a better job of training healthcare providers to do screening and use evidence-based practices, that we would be able to prevent a significant number of the suicides that our country experiences. There's a Nevada Suicide Initiative coalition across the state. Most of their work that they're doing is with hospitals. But here at the Health District, again, under the leadership of Joe Dibble, who's the health educator working in this area, our Clinical and Community Health Services Division is kicking off Zero Suicide here at the Health District. They've established their internal team and they are building their training schedule so that we will have that benefit for clients here at the Health District as well. One other thing that I wanted to note is that sometimes with all of these community coalitions and boards and things like that, one thing that is just needed is a little bit of time and a little bit of leadership. And so we're lucky here at the Health District to have the support of the District Health Officer. And I serve as the chair of the Washoe County Regional Behavioral Health Board. And Joe Dibble serves as the co-chair of the Washoe County Substance Abuse Task Force, co-chairing that with the representative of the Sheriff's Department. So these are areas where we're just providing time, energy, leadership around significant community boards that are working in this field. So that's my overview of the broad base of work that the Health District is leaning into when it comes to behavioral health. The rest of my presentation will be a little bit deeper dive into the Behavioral Health Crisis Response Initiative, so that one single initiative. So our crisis system is working to have an alignment of how we respond towards this common goal of meeting someone who's experienced a behavioral health crisis where they are, getting them the right intervention at the right time. So this is based on now what has been pretty well researched and documented best practices when it comes to behavioral health crisis response. There are some other communities that are much farther along than we are on this work. And so, for example, in Maricopa County, Phoenix, Arizona, they've been working on a model called Crisis Now for the last 15 years or more. And there are several other communities across the state, or I'm sorry, across the country. The idea of this model is that you have this person in crisis and they can call a crisis line. They will through the system, have a place to call, someone that can come to them, or somewhere to go. So the first step could be the crisis line. In the models across the country, typically 80% of calls can be resolved by that crisis line. For those that can't be resolved, we can dispatch a mobile crisis team. In the best practice model, that mobile crisis team is a team that includes a behavioral health professional and a peer recovery support specialist. Again, one of those individuals with lived experience. For 70% of those, they can be resolved in the field. And so for that last small amount that we can't resolve that crisis over through phone, text, chat, or by dispatching a mobile crisis team to them, there is a crisis stabilization unit or a crisis facility that can receive them and give them that subacute crisis care that they need. All of that gets followed by a post-crisis wraparound services to make sure that they can get connected to an outpatient visit or medication if they need it, or case management. And if we can do that system well, what we would see is decreased use of our jail and our emergencies departments as the primary place where people who are in crisis end up in our current system. The beauty of this kind of a crisis response system is that the least restrictive service also happens to be the least costly. So if we can transform our system so that fewer folks are ending up with a police response, ending up in jail, or ending up in the emergency departments, we can improve the level of service for the client while also reducing costs for the community. So that's the idea that we are driving towards. That's the concept. The change drivers for why is this the moment in time that our community is choosing to tackle this are a couple of things. First is just a need. I think we've all seen it. Certainly we had behavioral health challenges before COVID-19, but since COVID-19, the escalation in folks who are experiencing substance use issues or behavioral health crisis issues has been exponential. At the national level, the FCC has approved and will go live a new number called 988. So right now, if you are helping someone or if you yourself are experiencing a behavioral health crisis, you kind of have to search around to find out what is the crisis line phone number. But starting in July of next year, anyone will be able to dial 988, and that will dump you into a behavioral health crisis line. And so that rollout is sparking some enthusiasm and some need to be prepared to manage those calls that come in. There have been a couple of legislative opportunities that I'll go over here in a minute that are providing some framework and resources for this work. And then, of course, right now we are the beneficiary of some additional federal funding through ARPA and some of the other national efforts that are helping us to have an opportunity to invest in some of these systems. So those four things combined are really driving some change in this space, or at least some opportunity for change. So just speaking specifically about the National 988 rollout, it goes live on July 16th, 2022. We are lucky in the state of Nevada that there are 10 national lifeline centers, and one of them is located right here in Reno, Nevada. That's Crisis Support Services of Nevada. They cover the entire state. So those calls initially will go to Crisis Support Services of Nevada. There's currently an RFP out to see if they will continue to be the provider or if another provider will come forward for those services. But for now, it's Crisis Support Services of Nevada. And there's a statewide planning process because obviously wherever you are in the state, when you call 988, it's going to jump into the system. And so it needs to be something that is relatively uniform across the state. In the area of legislative opportunities, Senate Bill 390 created a crisis response fund. And so this fund will be filled with a new fee on everybody's phone line. So similar to right now where you have a 911 fee on your phone line, there will now be a 988 fee on your phone line. That small increase in fees will go into this fund. And these funds are specifically dedicated to funding that crisis response system so that when somebody does call 988, we know that they're going to get a good and meaningful behavioral health crisis response. Right now, the state is in the process of writing those regulations, so that fee has not been put in place. It's authorized through NRS. Once the regulatory process is over, that fee will go on phone lines. It'll take a year to collect enough money for the state to be able to make any distributions to put that money to use. Another significant area of legislative advancement was a bill in 2019 that came from the Washoe Regional Behavioral Health Board, which established an endorsement and created the concept of a crisis stabilization center. That endorsement is important because it then allows that agency to bill Medicaid. And obviously having a sustainable financial system for this kind of a project is important. SB 156 in 2021 helped to clarify that language so that we are now ready to go with endorsing crisis stabilization units or crisis stabilization centers, that facility or that place for someone to go if they're experiencing a behavioral health crisis and they can't be stabilized either over the phone or by a mobile crisis team. On the additional federal funding front, we have mental health block grants that happen every year through the state, but there's been supplemental funding for those mental health block grants. There's been additional ARPA funding dedicated to this work. The state has received a mobile crisis planning grant specifically for the mobile crisis team pieces of it. And there have been what we call NOFOs, notice of opportunity or notice of funding opportunity that has been released. We know that there are entities and agencies in our community who have applied for some of that funding to be able to be able to build out crisis stabilization or mobile crisis teams, but we have not heard the results of that funding. So we're expecting announcements in February of 2022. I was hoping when I wrote this that I might have news to share, but we have not heard yet who is receiving the grants locally to be able to implement some of this work. So as an overview of the process, the health district allocated the almost $150,000 to this project. The project was kicked off in June of 2021 and it runs through June of 2022. The participation includes the state, county, cities, law enforcement, REMSA, hospitals, the payers, by payers I mean the insurance companies, behavioral health providers, and other behavioral health stakeholders. And the deliverable at the end of this process will be a plan to try to take us from where we are in our current state, which has some good aspects. We're doing some good work, and move us much more towards the ideal behavioral health crisis response system. The framework of the project is that there's a leadership council, and on the leadership council, it includes the two city managers, the county manager, the district health officer, hospital leadership, insurance company leadership, REMSA leadership, and some behavioral health agency leaders. There's a technical advisory committee that is more the folks who have behavioral health technical expertise, working a little bit deeper in the organizations. There are then committees working on each of the three components of the system. So there's a committee working on the crisis call hub. That's that call center that can do text, phone, or chat and respond to crisis. There's a committee working on mobile outreach teams. And here I want to acknowledge in our local environment, we have most teams that are a law enforcement based team. They're actively participating in this subcommittee. And then they would work in conjunction with the best practice model of behavioral health professionals paired with a peer. And then we have a crisis stabilization subcommittee that's working on that crisis stabilization unit, that place to go. Finally, there's a committee that will begin working on resources and financing. We have not convened this committee as we are waiting to find out the results of the notice of opportunity of funding and where the federal funding will go and what the Medicaid rate is going to be for the crisis stabilization units. Can't really put together the pro forma or the business plan side of it until we know the answers to those questions. Some of the things that the project's working on: what is a sustainable financial model for this kind of work in our community? What is the collaboration between 988 and 911? So when a call comes into 988 that really does need a public safety response, how do we get it over to 911? And when a call comes into 911 that really is a behavioral health response, how do they get it over to 988? Some identification of the mobile crisis teams and crisis stabilization units. We do not have those providers currently in our communities. So hopefully through this NOFO, we will identify providers and provide some funding to them. What's the role of our current MOST teams versus the role of new mobile crisis teams? What's the role of the Crisis Stabilization Center? This is the new model versus our current Crisis Triage Center. How are we meeting the needs of children and adolescents? What do we do about the lack of capacity in the overall behavioral health care system? So it's wonderful if you can get somebody who's in crisis stabilized, but if they can't get an outpatient treatment visit or can't get a bed if they need a bed, how do we manage around that or to improve that? And then finally, what's the governance model on a go-forward basis? One of the key principles behind this work is not having isolated and in-silo behavioral health providers, but how do we create a true behavioral health crisis response system? And if we are going to be a system, how do we maintain that system over the long haul, and what's the appropriate governance model for it? So those are not the work that is finished, but the work that we are tackling through this project. And with that, I'll just pause and see if anybody has any questions.
Any questions or anything else? I'm going to be taking over for Oscar. He's had to leave for the moment, so I will be taking over. Julia, thank you for a huge amount of work. I mean, it's incredible, and obviously you just got things started, so thank you very much. I don't think it's an action item. Chris, do you have anything?
Yeah, I just want to say part of the reason I wanted this to come, and thank you so much. That's a lot of great information, and I'm really excited about our crisis plan at the very end, which you spent more time on. Is that the place we went and visited, that idea? Remember we went and visited a place over that could potentially be a crisis center? Is that the same idea?
Yes, Councilman, thank you for the question. For the record, Julia Ratty. So yes, one of the proposed locations for a crisis support unit is on the NAMS campus. There have been conversations that I'm aware of, obviously not deeply involved in, between the city of Reno and the state for the city of Reno to lease that space to be used for that crisis stabilization unit. And then we are in this waiting period for the notice of opportunity or the notice of funding opportunity results to come out from the state to see if a provider gets funding to be able to operate it.
Perfect. So one of my goals was for us to kind of look at this as a board as well. We do a lot of things assessing different portions of health, and this is obviously something that these guys are putting their hands on, but like was shared, we only, we're just kind of at the beginning. This is not really a strong place we've been in the past, it seems. I really see us having a place here that we hopefully can create, I'd almost say, how do I say it? an evaluation of the services for our community that we can at least assess and say, this is a high level priority, just like we do with our hospitals. You know, we know what kind of care is out there. And if there wasn't, we'd be able to kind of encourage or at least let people know. But when it comes to mental health, we've had a few movements happen in the years past that seem to shock all of us, like, oh no, so-and-so left, and this is getting, you know, they're canceling this program out. And then everyone's like, what just happened? But it only tells me a couple things. That maybe we're not paying enough attention here. And so who does that? And I think as a health board, I'm not saying we run it. I'm just saying we gather the resource information so we can show community leaders, hey, here's some of your problems you guys have, or hospitals or whoever. So I'm not at all saying that we all of a sudden become that place. But I also think if we're going to ever get grants in and really see some of this stuff, we have to know our information. But for me, even as a city councilman, there's times I don't. I mean, I'm trying to find stuff and I'm piecemealing information together. And maybe I'm looking in the wrong places, but I don't think so because I'm actively asking. And so I would love to help make sure that this is coordinated at large and then have that, like you said, mainly we're the community information people. I'm not, unless there's something more we want to do, but at least start there. Does that make sense, Ms. Ratty?
Yeah, thank you, Councilman. Again, Julia Ratty, for the record, I appreciate your enthusiasm for the project. I think one of the very motivational pieces is there's a lot of energy around this in our community right now, and the participation in the project. Because again, as you say, it's not necessarily the health districts. The health district was able to step forward with this funding to get the consultant, but we've had great participation from the county, the cities, the hospitals, the payers, the behavioral health providers. And that has been meaningful and important. And then I think there will be this question of, is there something, what does the governance and ongoing structure look like to make sure that that momentum continues forward? So we're looking at that. What are the next steps? The plan will get published in the June, July timeframe. Part of that planning process includes a conversation about what the governance or accountability piece of it should look like moving forward. And so I would say more to come on that. There are lots of different models, right? There's the Community Homeless Advisory Board as an example. There's the Hospital Coordinating Committee that you just saw as an example. There's very informal networks. Again, there's no NRS or ordinance or anything that drives this work specifically. So I think we have the opportunity to create it as a community, and that will be an important piece for all of us as a community to lean into.
I think that's good. I would just even say it this way. I mean, again, a super goal way down the road, but I could even imagine that we have some form of a dashboard that even just shows us how we're doing. How are we doing in this area? I don't know who would do that, but I think that us looking at large, so we're not surprised if there's shifts or things going on, that we know where we're failing, not to push on somebody, but to say, hey, if we're going to do some more, we need grants, this is for, and then where we're successful, where are we doing well? So just things to think about, but I don't want to sit back and just keep watching things happen, because that's what I feel like I've been doing for a few years. I'd really like to make sure that we have this information in front of us. Thanks.
Good.
Thank you.
Thank you both. I appreciate it. That finishes up the item 12. It's time to move on to item 13A.
Dr. Novak.
Yeah.
Can I ask Ms. Ratty a question?
Sure.
Thank you. Ms. Ratty, a question, and I apologize if I missed this within your presentation. Is the University of Nevada, Reno, is the med school participating in their, I mean, one of the issues I do hear consistently throughout the region is that providers, the lack of providers available to help with the outreach, with the medical outreach, aren't as readily available as we need, because our numbers are way out. The numbers of individuals needing the service way outnumber those of the providers available to provide the service. And I'm sure Dr. Danko can, reaffirm that. Are we working with the university to create, I mean, since we are developing this program, are we working with the university to help maybe funnel some of those providers or some of those students into the program and help have them participate in the formation of this?
So it's a great question, Commissioner. Thank you for the question. Again, Julia Ratty for the record. Trying to answer your question, the university is not a specific partner on the crisis response implementation plan project. That project has a box around it that is specifically how are we rebuilding how we respond to crisis, and particularly how are we shifting away from 911 to 988 and then everything that comes from it. So they didn't necessarily have a specific role. I do not want to end there, though, by saying that there aren't meaningful conversations in other places where we are collaborating in coalitions around developing the behavioral health workforce, because that is not an issue that is specific just to the crisis response, but is specific to the entire behavioral health care system, where we have, as you have noted, a significant shortage of behavioral health professionals. And often what's happening in our community is we're just hiring them away from each other, competing to get the small number of psychiatrists, psychologists, marriage and family therapists, except APRNs with a mental health endorsement. So that is a significant issue. The university is absolutely at the table, and it's just a different coalition or a different gathering place where that is happening. So not necessarily specific to this project, but yes, workforce development is a big issue in our community, and good people are working on it, including the university.
And as it pertains to the 988 number, obviously that'll be statewide, or is that a statewide number, or is that a national number, or how will that work?
It's national, anywhere in the country. I'm sorry, Julia Ratty for the record. It's national, anywhere in the country. And it is built on top of the current Lifeline system. So there's already a behavioral health crisis Lifeline system across the country, but you have to go find the 9 digits to be able to call it. And so those Lifeline centers, there's 10 centers across the nation, and they have backup capacity for each other. So if our Lifeline here in Nevada is receiving a significant number of calls and there's capacity in another Lifeline, they can roll over to another system. What's being built, though, then is that connection between that existing system. So once 988 goes live nationally, anywhere in the country, you can call it. It gets funneled to Crisis Support Services of Nevada. What's the good response that we can do here in Washoe County to that person who's just landed at the Crisis Support Services call line? And so that's building out more capacity for them, including chat, text, and call function, because we know we've got a whole new generation that doesn't necessarily pick up the phone, but they might text you when they're in trouble, or they might chat with you when they're in trouble. And then it's building that connection with 988 and 911 to make sure we're getting folks to the right place. And then it's building out that ability, if you can't stabilize them over the phone, chat, or text, that you can dispatch that mobile crisis team or get somebody to a crisis stabilization unit. So that's what the plan. 988 is happening, it's coming, we have no say. On July 16th, it will go live, but we're making sure at the local level in Washoe County, we're building out a good response. Did that answer your question, Commissioner?
It did. Thank you, Ms. Ratty. And then, and a follow-up to that is, based on it being a federal number and a rollout coming in July, I'm assuming, and this is an assumption, that the federal government will be in charge for the funding necessary for the PR rollout of the 988 number. And so funding necessary for that rollout will come from the federal government, not from the health district in regards to how we do that. But will we have some discretion in regards to how that gets rolled out within Washoe County?
So again, a good question, Commissioner. Maybe beginning with the end in a more pointed fashion, the health district doesn't have a financial commitment to do the rollout for the 988 promotion, if you will. I believe that there are federal funds that are part of the mental health block grant process and the additional ARPA funds that are going to help to stand it up. I also believe that the state planning process is leaning towards a softer rollout at first. July is right around the corner. The system is not completely built. And so those promotions will build. I don't want to minimize the mental health challenge by comparing it to a restaurant soft opening, but maybe you have friends and family who run restaurants. You kind of are open quietly to make sure you get it right and then start really promoting. I think that that's the strategy that is being talked about at the state level. But the 988 rollout is really a statewide issue because we have that one Lifeline Center and it serves the entire state. So that's a planning process that's happening statewide and has been funded statewide. There's been no ask for local dollars to do that. It's all been done with state and federal dollars. And then we're working with this small pot of money from the health district to do the planning process to make sure we can get the response right.
Okay. I guess one last comment is that as we do service primarily, obviously, Washoe County and all the residents within, we do also support a number of Northern Nevada communities where we act as that kind of that base for our surrounding counties, not only in Nevada, but also in California.
So, great question again. I would say where we are right now is we are very focused on building out Washoe County. We certainly understand that we are a hub for the region. In some ways, Carson is a little bit ahead of us because they already have a crisis stabilization unit. So they actually have the facility piece of it already in place. In the rural communities, they're still working on building out some of just the basic components, right? We're very different places across the state in terms of our capacity. The PSAPs, meaning the 911 operators and the 988, that all gets handled at a sort of technological level of where those calls land, right? And so I believe that if you're in Truckee and you call 988, it's going to go to a certain place. If you're in Reno, it's going to go to another place. But certainly it will have the regional impact of if we do a better job of this, as I believe that we will see, as we always do, folks coming into the urban area for additional services. But right now, the capacity that we have is to focus on building out Washoe County, and we're not thinking, honestly, much more, just speaking frankly, we're not thinking much more broadly than building out Washoe County.
Well, if I can meet with you offline and we can and maybe talk about it from a more of a regional standpoint and how we can participate, not only from a Washoe County standpoint, but also from, a sister county. I'd love to sit and collaborate and see what there are some opportunities, if there's informational rollouts that we can help, because knowing some of the challenges that are occurring in our rural communities that we do serve, this is a massive issue that it takes a lot of undertaking. And I first want to commend you for all the work that you've done, but I'd like to see how we can continue to collaborate and continue to build upon what you're saying. As you said, we just continue to structure this so that it is highly functional. It isn't siloed, that it is really truly an outreach for those, because as you've worked on, most of these individuals that might participate in a program like this sometimes are transient, and we want to make sure that we capture a lot of those individuals through the 988 situation. It'd be helpful for me if I could have a little bit greater of an understanding of the rollout and in that outreach.
Thank you, Commissioner, and I appreciate that clarification. I may have misspoke then. So the promotion is statewide and does go across county and would be very collaborative across all 17 counties, frankly. I was speaking more to the response. So when you get down to the dispatching a mobile crisis team and a crisis stabilization unit, that we're really focused on standing up 2 services that don't exist in our county yet. Right. So that part, we're really very focused on Washoe County. Yeah. So I just want to make sure that I didn't misspoke on the promotion side. Absolutely. It's definitely going to be a statewide collaborative. It is very much a statewide collaborative effort.
Marvelous. Yeah, if I could meet with you offline, that would be fantastic.
Of course, always happy to.
Thank you.
Vice Chair, I'll turn the meeting over to you to finish.
Okay. Thank you, Dr. Novak. Member Clacking.
Didn't have it on there. Ms. Reddy, I had a couple of questions real quick. First, congratulations on this. I think this is tremendous that we're moving forward on this and making that 998 number just sounds like a very simple solution to help pick up what we can do in this behavioral health area. My question is this, about 75% of the suicides in the United States are male, and with the highest rate in the Mountain West area that I've read before. So our area has the highest rate of male suicide in the United States. The callers coming in, I've always wondered about this, how efficient that is. Do you know what percentage of callers into those hotlines are male and female? I would guessing that it'd be more equal than that because males don't tend to reach out as much. I was thinking.
Thank you for the question. They're clacking. So I think in the middle of the presentation, I noted that I just get to be the spokesperson for a whole bunch of people who are doing a whole bunch of work. And so I wish that I had the executive director of the Crisis Support Services of Nevada sitting next to me to be able to answer that that question, because they are the call center. I'm certainly, I can get that answer for you and bring it back to you, but I do not know the answer to that.
Okay, thank you.
You bet.
Any further questions for Ms. Ratty on this item? All right, seeing none. This is a non-action item. We will move on to item 13. This is the Regional Emergency Medical Services Authority discussion, and I will turn it over to Director Dean Dow.
Good afternoon, Vice Chair and members of the board. Dean Dow, President and CEO of REMSA Health and CareFlight. You've received your copies of our January compliance report for your review, and as always, I stand available to answer any questions that you may have.
All right. Are there any questions for Mr. Dow in regards to the REMSA operations report for January? All right, seeing none. We will move right along. We will move on to Alexia for our public relations report for January. Alexia, welcome. Nice to see you.
Hello, nice to see you. Good afternoon, Mr. Chairman, members of the board. Alexia Jobson, Director of Public Relations for the record. You have for your review the public relations report for January, and I have a few other things to share with you today. At the end of January, REMSA Health hosted United States Senator Catherine Cortez Masto, organizational leaders, and subject matter experts.
$1 billion for the fiscal year, primarily related to inflationary increases with cost of labor, fuel, medical supplies, PPP, and related operating expenses. So accordingly, we're going through and looking at non-patient expenses and deferring where we absolutely can to offset some of the inflationary costs that we're experiencing. Some of the non-financial stuff that you might want to hear about as we remain focused on our philosophy and culture on the employees and on our community. In the past year, we adopted a 40-hour work weeks for our field personnel and gave them employees a 3.5% wage increase in July. Each REMSA receives a little over 80,000 calls annually for service, and we transport approximately 50,000 patients annually to area medical centers. Services are provided to all patients regardless of their ability to pay, and we only charge patients when transportation to a medical center is completed. Approximately $3.2 million is the cost of the uncompensated care related to transportations that are unfunded. We employ a little over 500 people, most of whom live here and work in the community. And our patient payer mix is about 20% commercial insurance, 43% Medicare, 30% Medicaid, and about 7% patient billings. All of this information is in the report that we included. As a board and an organization, we continue to look for ways to improve our efficiency and expand patient care in our region. I am happy to address any questions about the finances of the organization. It's always good to give good news to the board.
Thank you, Mr. Nelson. I do appreciate it. Are there any questions for Mr. Nelson in regards to the financial audit?
Thank you.
All right. Mr. Nelson, I want to thank you and congratulate you and REMSA and all the executive staff and all the team at REMSA for your ongoing continued work to make REMSA a financially stable organization and continue to bring that forward. Under your guys' leadership, we've seen some great strides. Congratulations.
Thank you, Chairman.
All right. Seeing no further comments from the board, we will move on to item 13D. This is an EMS systems update on hospital offload delays, mutual aid, the nurse helpline and ILS, and the assess and refer in community education. This is presented to us by Adam Hines with REMSA. Adam?
Good afternoon, Mr. Vice Chairman, members of the board. Adam Hines, Executive Director, Integrated Healthcare for REMSA. One of the things the board asked at the last meeting was to receive an update on some of the system enhancements that we put in place, as well as some of the climate, specifically offload delays. So I'm happy to present that. You know, the first thing that I'd like to talk about is the hospital offload delays. Our community has, like every community in the United States, has had challenges with offloading patients at the hospitals. But I think that there is a lot of positive, or at least light, that we are seeing. This graph here is represents the efforts in January. So this whole presentation is really going to focus on the month of January, or we'll show a couple months. But what this specifically shows is each individual day in the month of January, and then the shaded area in gray is the percent of times in which a unit experienced an offload delay. And as you can see, that trend line continues to go down. I believe in the month of January, 7% of transports experienced some sort of offload delay. Some days worse than others, but we also know in the month of January, we saw an increase in the number of calls for service, as well as our hospital partners were working hard to take care of patients in our community suffering from many different illnesses, including COVID. And so I obviously don't have all of February tabulated yet. However, February is trending in the right direction. We're currently at 3%. So that continues to go down. If we take a look since September, really in September, we experienced a significant increase in the number of units that were experiencing an offload delay. You can kind of see how, again, we're starting to see not only the number of incidences, but also the percent in which the units are experiencing these delays. A little more, I think that this shows you almost every single day since September. And again, that trend line is going in the right direction. One of the things that we did on the 14th of January is there's actually a Nevada revised statute. It's 450B 790. And that essentially outlines that our partnership with the hospital, when an EMS unit arrives, that within 30 minutes, we will transfer care over. And you know, we've struggled with that previously. I'm very pleased at the efforts that all of the hospitals have actively participated in over the last couple months at really highlighting this issue, understanding that our healthcare, ecosystem in the community, it's vital that ambulances are available for emergencies, and waiting in the hallways of the hospital is not the best use. And so our hospital partners really worked very hard with their internal teams to adopt this on the 14th of January. And I think we're seeing some of the fruit of that hard work in the number of incidences in which our units are being held on offload delay. Specifically for times, and I think it's important for the board to understand that any time an ambulance arrives at a hospital and they are unable to transfer care within 10 minutes, we essentially alert our dispatch team that the ambulance is in offload delay because they potentially would be available for another call in our community. So offload delays will continue to happen. However, one of the things that we're really rooting to do is obviously reduce that so that we're down under 5% of the time. In addition, we're hopefully trending the median time in which a unit is delayed at the hospital, as well as the maximum delay. And as you see, we had a little bit of an uptick in January. Again, I think that there was a heavy census in our healthcare community. In addition, there was a maximum delay over that 30 minutes, but that was right before the 30-minute directive was pushed out to the hospitals. And so I think next month, if you wish, and I come to the board and share this information with you, I have confidence that we will see even better numbers for the month of February. And then finally, as relative to the hospitals, this is the number of times in which our hospitals went on delay. And I think we've had many conversations about, what that does to the dynamics of the EMS system. That requires our people, when they arrive on scene, to have awareness as to which hospitals open. In addition, because sometimes that's dynamic when you're transporting patient, it requires them to divert to potentially a farther hospital, which kind of puts them out of place and requires a longer time in which they would be caring for that patient, reducing their availability for the next. Now, I will share with you, there obviously was an increase. However, we changed the way the hospitals did this. And again, I can't thank the hospital partners enough and really their cooperation in doing what's best for the community. And so if we go back to September, one of the things that was done was multiple hospitals could be on divert at one time, which essentially could potentially put us in a position where only one hospital was available, which really puts a lot of strain on that individual facility, especially some of the smaller facilities. And so with collaboration with our co-response partners and the hospitals, we were able to devise a temporary diversion plan that allowed hospitals only to go on one at a time and for a limited amount of time, for essentially 2 hours, and they had to reevaluate. And so that's really why we see an increase in the number, is because we restricted the time, and there may be multiple hospitals that are going on at that time. But we really think that that may potentially pave the way for a future or even indefinite way in which we handle hospital diversions, because it really has equalized some of that pressure in times of surge. The other question that the board had asked was about mutual aid. And this actually, we report mutual aid to the EMS Advisory Board quarterly, but I went ahead and pulled January statistics. So Remsa Health responded to 7,217 calls within our jurisdiction, and we requested our mutual aid partners 15 times. As you see, 10 from Reno and 5 from Story. Now, one of our co-response partners is missing, that's Truckee Meadows, and so this doesn't 100% provide us with an accurate picture as far as the total overall. And the reason for that is, as you know, Truckee Meadows is now one of our partners in our dispatch center, and how we categorize those calls for mutual aid changed when they came over. And so our data analysts are working very hard to ensure that we are prepared for any subsequent presentations, that we're able to accurately provide you with that. But I do think it's important to just at least see what our partners at the Reno Fire Service as well as Story County are doing to help assist when there are times in our community where our assets are consumed by emergency calls. The other is patient navigation. And, just to review, when somebody calls 911 and that call is handled by one of our medically trained dispatchers, we begin to prioritize that call. And that is really so that we can navigate that patient to the right level of care safely. And so our dispatchers use an evidence-based, very algorithmic protocol set that will essentially provide them with a recommendation based on the patient's complaint. Some of our patients will go to our registered nurses that are here 24 hours a day. Some will receive intermediate life support response. Those are many of our behavioral health patients, individuals that may have fallen and have minor injuries. And then the rest of our patients in our community receive an advanced life support response, which is our paramedics. And we want to ensure that they're available for emergencies. Specifically, the intervention, which is our nurse health line, each month essentially takes around 100 calls out of the 911 system. And, when we're talking about 7,000 responses, 100 calls doesn't necessarily seem like a lot. But on average, it takes our crew members about an hour to handle that call. And so 100 patients that were navigated to the right level of care, really, when you compound that by an hour and then downstream, potentially using the services of an emergency department that may not be necessary, does make an impact into our health ecosystem. And so for the month of January, there are actually 463 eligible patients However, only 106 were transferred over. And then only 4 patients actually repatriated or actually were returned back into the 911 system. And typically, the majority of those patients are not because of acuity, but because of either a logistical issue. So the patient lives on a second floor and may be wheelchair bound, and a taxi would not be an appropriate mode of transportation. And so our crew responds. Or the patient may be demanding an ambulance. But we have very low, of those 4, only 2 of those patients returned because of an actual higher acuity medical complaint. The other intervention is intermediate life support, and that is essentially, we have paramedics in our advanced life support units, and then we have advanced EMTs that can start IVs, they can give some medications, they can provide analgesia through nitrous oxide. And in the month of January, the ILS unit handled 8.3% of our responses, which essentially was 603 calls. They transported 521. And as you see, the top 5 calls there, 47% of those are hospital-to-hospital calls. So those are individuals that may be transferred from an emergency room back to skilled nursing or from one facility to the other. The other 17% is, again, behavioral health or psychiatric emergencies, which we know are one of our highest calls for service, or one of our top calls for service in our community. The other 7% are calls either for palliative, interfacility, or transfer from an urgent care doctor's office, and then 5% are for falls. Of those calls, and on the 12th of January, we expanded outside the McCarran Loop, and I included a kind of a map of where these calls occurred so that we can see that the majority of these calls actually continue to occur within the McCarran Loop. Of the calls, the 603 responses, only 5 of them in the month of January requested an ALS co-response because when they arrived on scene, the patient's acuity was higher than what they could handle, so less than 1%. For alternative destination, this is another way in which we can decompress the utilization of emergency rooms by transporting a patient or providing telehealth. We still are not capitalizing and maximizing this, and there are many different barriers. And I think over the next couple months, we're going to work with community stakeholders and ensure that the community becomes much more comfortable with navigation. You know, the 911 call's changing, and one of the things that is expected is when you call 911, the only way to receive care is either in the back of an ambulance or at the emergency department. So we're going to continue to work and hopefully help educate our community members so they're more comfortable. But for the month of January, we were able to navigate 14 patients and get them out of the emergency rooms and get them to urgent cares, behavioral health, or perform telehealth. The other intervention that was new that actually was launched in January, and I came before the board, I think last month or the month before, was assess and refer. And a reminder, this is for adults who have capacity, and they're complaining of many things in which likely could be handled at an urgent care via telehealth, their primary care, or even at a pharmacy. And so there are specific requirements, and there is guidance from our medical directors as to who we believe can safely engage in this protocol. And, again, this is not a refusal to transport somebody. This is merely based on your current complaints and based on your medical history and vital signs. We believe it's safe that you could seek care somewhere other than receiving an ambulance transport and going to the emergency room. As of this presentation, we have done 25 of these. This is documented for the purpose of this. At the time when I submitted this, we started on the 19th of January, and 10 individuals were eligible. We review 100% of those records, and 2 of them were for body aches. 1 was for a urinary tract complaint. 5 were limb pain or wounds on a limb. 1 was for vertigo, tendinitis, and then 1 was a GI complaint. That one that was asterisked was a patient in which was outside of protocol, and after review, it actually fit protocol, but that was the provider's impression. But I think at least that should give the board comfort that we are reviewing and following up with people and ensuring this is safe for our community. Chairman Delgado had requested that we provide a map that kind of shows where these calls are, and that's what these pin drops are showing, is where these calls are occurring. And then finally, we did repatriate, essentially having to respond to a patient that was something we track as if we come in contact with that patient within 72 hours. And of this subset, there was one patient in which we actually responded 5 times for various complaints and transported him twice to local emergency departments. And since that individual has been referred to our community health program. The other part of this is we want to make sure that we follow up and gather data so that we understand how that experience was from the patient's perspective, as well as really understand, did they follow the care that we recommended? And so these are comments just from that subset from our nursing team. So within 24 hours, a registered nurse calls the patient if they have a phone, and we have a phone number for them, and they will contact them and they'll ask them, how was your experience? Did you follow up with as directed? And is there anything that we can do? And if they have a complaint, they can go through a protocol and either send them an ambulance or get them where they need to go. And I was surprised and very pleased to see that the majority of comments for that first subset has been very positive. And I think I shared this with you last time. This is actually the form in which our patients get that provides them with some access to additional care resource, kind of tells them about their complaint and what we found, and then is a little resource guide that provides them with just a little bit of some of our community resources. And then finally, I know this board was very concerned and rightfully interested in what our efforts were to educate the public. And that obviously is going to continue for over a long period of time. We're going to have to continue this messaging. But some of the things that we have done and are going to continue to work to do is obviously media coverage, social media posts, mailers to some of our frequent utilizers and actually sharing them and educating them about the program so they're informed. Employee training and education. We have this explainer video, which our Director Jobson shared with us last time. A multimedia awareness campaign we launched, Choose the Right Care, which is an interactive place where people can get information, working with our constituents and policymakers and having those discussions. And our co-response partners. I'm really very thankful that every other week we're meeting in a joint meeting with our co-response partners, which include Reno Fire and Sparks Fire and Truckee Meadows Fire Rescue. And we're really having these conversations as how it affects not only their jurisdictions in their communities, but how can we work cooperatively so that we're reducing everybody and making sure we're singing from the same sheet. And so with that, I also thank Councilman Dare and member for working with us to get that out on and using some of his platform to ensure that we were able to communicate to individuals in the city of Sparks about this change. And so with that, I appreciate the time. I'd be happy to answer any questions, and thank you.
Thank you, Mr. Hines. Do appreciate the update and report. Nice to see that the offload delays are definitely becoming less arduous and complicated for REMSA. That's always a positive update. Are there any questions from the board in regards to any of the measures taken by REMSA? All right, seeing none from the board. Minister.
Sorry, what is some of the training we're doing? One of the concerns that I mean, communication's it, and that's huge important, but then also just assessing of the situation to make sure we're not leaving somebody that needed to have that kind of response. You know, what kind of training are you guys doing? I say this more, I think we've talked about it once, but even for our public to understand that this is, we're putting all into this and making sure all the we're not leaving somebody behind that actually needs help. We're not leaving them there. They're getting the help they need, and we're assuring that. What kind of training are we doing?
Thank you, Councilman Dare. Adam Hines for the record. So this starts, there are many communities across the nation, really actually not the majority of them, but there are a few communities across the nation that are really rolling out similar things. And so we look to them to obviously, one of the ways in which we ensure patient safety is through the construction of a protocol. And one of the things that we have had the opportunity in this community for at least 10 years is use the transport to urgent care protocol and use that as a basis to really safely triage patients. And we have data based on 10 years of transporting patients to urgent cares as far as a lot of those outcomes. So we had a little bit of comfort moving forward that our team members are able to, with some sort of specificity and sensitivity, to be able to identify these patients. But that also requires constant training. And so that is occurring with our senior field training officers when we onboard new people. We have online training that includes excerpts from our medical directors. So we have two physicians that are a part of our organization that take time to provide education to our team members. And then obviously a very robust quality process where we're constantly monitoring those cases and ensuring that if there is something in which we need to do to adjust for the sake of patient safety, we're doing. And I think that extra step is that our nurses, which provide an additional net that allows for us to contact the patient, check in with them, make sure that their symptoms are either getting better or they're managing them or they did whatever we told them. And if not, send them the resources they need. So I'm hopeful that as we continue to progress, that those, what we're doing is really changing the way that we provide care. 30 years ago, when somebody called 911, you loaded them up and you drove as fast as you could to the nearest hospital. And the new generation of paramedics and EMTs are now being taught there are different ways and different paths that we need to treat patients. And these are the ones in which are best managed safely through these mediums.
Thank you. It's good. Appreciate it.
Thank you.
All right. Any other questions? Seeing none, we will close this item and move on. All right, Mr. Kevin Dick, I'm going to turn it over to you for public hearing. We're going to open the public hearing for item 14, sir.
Yes, thank you, Vice Chair Lucy. So this is a public hearing. I will open the public hearing and we'll turn it over to Francisco Vega. This is for possible adoption and proposed revisions to the District Board of Health regulations governing air quality management, section 040.051, to reduce emissions, attain national ambient air quality standards, and update wood burning device rules. And so I will turn it over to Mr. Vega.
Thank you, Kevin, and thank you, Vice Chair Lucy, members of the board. For the record, Francisco Vega, Director of the Air Quality Management Division. I do have a presentation. I just want to make sure you guys can see it.
Yes.
Yes. Good. I'll go through it pretty quick. A lot of the information is a repeat of what was presented last month, but I would like to update on a couple of things. So again, just some information I'll be providing. Really proud of the stakeholder and public engagement we went through in this process. The purpose of the revision, next steps, and then I'd be glad to entertain any kind of questions or comments. So again, we went through an exhaustive stakeholder process in developing this regulation. Again, we had 3 stakeholder workshops in November. And again, this was with real estate agents, title companies, inspectors, box stores, city and county building officials. So again, we wanted to really make sure that we engage with these stakeholders and hopefully address any kind of concerns that there might be. In December, we held a public workshop. And again, all public comments that were received have been addressed, and those responses have been included in your board packet. Last month, the business impact statement was approved. by the Board of Health, and no comments were received. Again, the purpose behind the revision, we're looking to add clarity, transparency, and consistency to the implementation of the program. Also, we're looking to revise any language to remove ambiguity and clarify the intent of the regulations. Next, we're looking to reorganize for easier reference. And then also we are looking to add compliance flexibility and clarify requirements for device exemptions in order to address any kind of inconsistencies there may have been in the program. Lastly, we also clarified and added some additional definitions. Again, I went over this table last month, but again, this is just from a visual perspective. You can see there used to be 2 really compliance options. Now there are really 5. So again, this is our effort to really work with the regulated community and provide those compliance options. Next steps, hopefully the rule is adopted here today, the rule is adopted here today. We will continue to engage stakeholders throughout the rest of this, I'll say between now and July 1st, which is the effective date of the regulation. Really, again, just to make sure that the stakeholders understand what the expectations are and everybody is successful. So with that, I'll take any comments and questions. Before I do that, I just want to mention if the board would look to approve the regulation, there is an example motion available in the staff report.
Thank you, Mr. Vega. I do appreciate it. Before we go to, are there any comments from the board in regards to specifics as it pertains to the revision to the public, revision for the ordinance? Councilman Dare.
I just want to say thank you to your team for making sure you reached out. And I know we do this all the time, but it's something we want to make sure people know we're collaborating, we're listening, and doing our best to make sure we gather information and make decisions together. So good job on that. And I know you worked hard on that.
Thank you very much.
Thank you, Councilman Dare. Any other comments? All right, seeing none. I'm going to open public comment as this is a public hearing. Ms.
Yes, sir. We had Ms. Cindy Martinez signed up for public comment, but I do not see her logged on anymore. But if she is listed under a different ID name, if she could unmute herself, she could start her comment.
All right. Ms. Martinez, have you signed in? Are you available? Once, twice. I don't see her anymore either. So we will move on and close public comment. All right, with that, I am looking for a motion to move forward with acceptance.
So moved.
I have a motion from Dr. Novak. Do I have a second?
Second.
Second from Dr. Clacking.
Vice Chair, sorry to interrupt.
Yes.
I think because
you want the specific motion, Mr. Vega?
I would defer to the DA, but I think it might have to be specific too, because we do have an effective date in there as well. So.
Okay, so let me go back and I'll restate the motion for Dr. Novak and Dr. Clacking, and then they can approve that motion as needed. So the motion should be to adopt the proposed revisions to the District Board of Health Regulations governing air quality management, section 040.5051, wood burning devices with an effective date of July 1st of 2022. Dr. Novak, do you agree to that motion?
Thank you for restating it. I approve it. Yes.
All right, and Dr. Clacking?
I second the motion.
All right, so we have a motion and a second. We've stated the date and effective date of that motion. And I'm getting a nod from our district attorney that is okay. All those, I'll call for the vote. We've taken public comment on the public hearing, call for the vote. All those in favor signify by saying aye. Aye. All those opposed? Motion carries unanimously with all members voting. All right, then, all right. Right, so we are going to move on now to item 15. This is the approval of the fiscal year 2022-2023 budget. I will close the public hearing. So this next item is no longer a public hearing. So we'll close the public hearing and move on to item 15 for the agenda. This is the approval of the fiscal year 2022-2023 budget. And with that, District Health Officer Dick will take us into that.
Yes, thank you, Vice Chair Lucy. And Susie, if you could put the slides up. I want to first begin by thanking Anna Heenan, our Administrative Health Services Officer, her FCOs, all our division directors and their staff, as well as staff in my office for putting the budget together. And I'm going to review for you just briefly some of our recent accomplishments, the health district programs that are funded, summary of our revenues and expenditures, the FY23 sources and uses of funds. If you go to the next slide, Susie. The impact of this budget for FY23 on our future fund balances, and then next steps in our budget process. Next slide. So we did provide a more comprehensive list of accomplishments in the staff report, but recently we have continued to maintain our public health accreditation. We have received the Washoe Impact Awards for the Managers Award and the Effective Communication Award for our COVID-19 response during this past year. And we were also awarded the 2021 Samuel J. Crumbine Consumer Protection Award for our outstanding food protection services. And we provided over 200,000 COVID vaccinations through our operations, as well as integrating the COVID vaccinations into our daily clinic and assisting the community with access through multiple community pod events. Next slide, please, Susie. The budget is organized with funding for 22 program areas that we have at the health district. So these are the program areas for the budget. And I just would note that we have not established like a separate COVID-19 program area. The grant funding that we have received for the COVID-19 response has been incorporated within our immunization and epidemiology program areas. These are the same 22 programs that we've traditionally funded over the past number of years at the health district. Next slide, please. So to run through for the Office of the District Health Officer, our budget includes 14 and a quarter FTEs. We have 4 FTEs that we have added during this current fiscal year that we're in because of funding that we received, a pass through from the state from CDC for health equity. And those 4 positions include a communications specialist, health equity coordinator, and 2 community organizers. So I introduced Camarina, our health equity coordinator we just brought on board earlier today. So those 4 positions, plus we're adding another above base position for the FY23 budget. Included in that 14 and a quarter is a deputy health officer position. That's to assist with span of control issues for me in running the health district. Then we, under revenues, that $800,000 is that health equity grant that we received. The total budget of about $3.4 million for my office includes also $500,000 that we have for community health improvement projects. Ms. Ratty previously identified some of those that we funded with past budget funding for behavioral health. It also includes funding for surge staffing. It includes $45,000 for workforce development. That's for district-wide workforce development type programs that are aligned with the plan that Ms. Lavoie presented. It also includes $375,000 for the health district rebranding name change initiative. The Administrative Health Services Office has 10 FTEs proposed for FY23. That includes 1 additional fiscal compliance officer position, and that's to support the sound fiscal management for the overall budget of the health district, but also to enhance our ability to submit for and manage grant funding for the health district. So the FY23 expenditures for that office, $1.765 million. The air quality management program, total FTEs of 20 and a half. That includes one FTE that we're adding in the FY23 budget. And this is in anticipation of regulations that are being worked on now by air quality management that would come to the board in anticipation of approval of those. These regulations would set a 5-year renewal period for air pollution control permits. And so currently there's no renewal period, so we have permits that get outdated. So if that was to get approved, this position would be hired to support that workload on the renewals, and we would have, we're proposing fee funding that would support that position. So total FY23 revenues for air quality management, almost $4 million. And these come from 2 grants from federal EPA, from pollution control funds that we get through state DMV based on the smog check certificates, and also fees for the permits and services delivered through air quality management. Next slide, please, Susie. The community and clinical health services, total program FTEs are almost 77. We have had 9 positions added this fiscal year that were grant funded positions where the funding came in, and these have been approved during the year. 2 were for STD prevention and control under a grant from CDC, 4 for COVID vaccination efforts, and 3 community health workers that are part of that health equity grant that I'd mentioned previously. There are additional 4 above base requests for CCHS. One is a supervisor position to assist with the span of control that we have issues in that division with a number of staff that have been added, and 3 other positions that are administrative also to support management and supervision in that position with those responsibilities. In environmental health services, we have total FTEs of 43.75. We aren't proposing any additional FTEs in EHS this fiscal year. We do in the budget have 3 reclasses that are being considered for counter staff based on duties that are being performed, perhaps out of class for them. And but I just want to also remind the board that we will be continuing to work on workforce span of control and workload issues. And I anticipate there may be some additional FTEs coming in the following year budget as we get further into that for EHS. This has total revenues in the budget of a little over $4.5 million. That primarily is coming from fees and services. There are a few grants, but don't bring in a significant amount of funding. And then there's also tire fund money for the tire sales that occur in Washoe County for solid waste that come to environmental health services. Epidemiology and public health preparedness, total FTEs at 27 in the FY23 budget, total revenues of a little over $5 million. This is coming primarily through grants and a significant uptick in this number because of the COVID response funding that's flowing in the EPI program. We also get funding from the birth and death certificate fees rolling into this division. And then our expenditures for FY23 of a little under $5.7 million. To back up on the FTEs for this program, we've had 3 that have been added that are grant funded through the COVID response during this fiscal year, 2 for tech services support and 1 statistician. And we have 1 position that we have included as an above base in the FY23 budget that will support data entry and assistance in the vital statistics program. Next slide, please, Susie. So overall, our budgeted revenues for the health district, just under $29 million, about $5 million of dollars increase over the FY22 adopted budget. 4 million of that increase are coming from grants that we have for the COVID-19 response. Most of the remainder of that money is a result of the board's wisdom in building consumer price index increases into the fees that we charge. So those are adjusted each year based on the consumer price index, and that's helping to bring in those funds. So licenses and permits bringing in just under $4 million. The grants of $10 million, up $4 million, mostly because of COVID response funds, or some of that CDC grant funding that we got, health equity as a result of the COVID pandemic. We have intergovernmental transfers. Both of these, I believe I mentioned, the air quality program gets the pollution control fund, solid waste management gets the tire fund money that helps support the budget. Charges for services or other things that aren't technically permits that we issue and provide. So we've got a CPI increase on those for just under $4 million coming in total. And we're projecting some increases in the air quality management dust plans based on the development occurring, as well as birth and death certificates based on what we've seen with growth in the community. And then our miscellaneous funds, a small amount, just over $200,000. That money that's coming in for chronic disease support is from a nonprofit, but it's actually a pass-through funding from the state chronic disease program that we're getting through them. And then we have REMSA that's providing funding also towards support of the EMS program in the amount of just under $72,000 in the budget. And then we're continuing in our budget with level funding from the county general fund support for the health district at about $9.5 million. And we've been able to keep that level since FY19. Next slide, please, Susie. So this is the pie chart view of the health district budget for revenues. And the general fund support is down to 33% of our budget, which is the lowest that it's been since I've been health officer. I would note, though, that the federal and state grants has grown to over $10 million of our funding. So that's a big chunk of that is from the COVID response grants that we've received. And just for the board's kind of visual and thinking on this, the federal and state grant dollars used to be about equal to the licenses and permits before we had that influx of the federal funds. So with taking out the half the chunk of that red piece of the pie, that could be closer to what we've seen in the past and what we may see in the future. Although we're hopeful that there'll be more of a commitment to public health funding based on discussions that are happening at both the federal and state level. Next slide, please, Susie. So in our total budgeted expenditures, those are at about $31.6 million. That's up about $6 million over FY22. And this is represents about a $2.76 million deficit that we're proposing for the budget. And that's related to the fund balance that we've accumulated at the health district. The salaries and wages at $15.2 million, up about $2 million, and that's attributable to the increase in FTEs that we're seeing from both the grant funded projects that have come in during the year and those 8 new positions that we're proposing in the above base budget. It incorporates also employee merit increases and we have budgeted 4% for a cost of living increase for staff. There are a few uncertainties in our budget, and that's one of them. The county is in negotiations with the labor organizations for collective bargaining agreements, and we don't yet know what the COLA increase that's going to be agreed upon will be, but we have 4% built in there now. The employee benefits coming in at about $7.7 million, up about $1.4 million. We had included in this budget, we felt that we were going to go back, the county was going to go back to paying a larger amount for the retiree health benefits for future liabilities. And it's called OPEB is the acronym with the county on that. But we've found that they aren't going to be increasing to that amount that they were paying in the previously and before last year in their budget. And so that's about $400,000 of padding it looks like we've got in the budget right now, depending on what goes on with the COLAs and other things. Since it's not going to be fully needed there. And then the other increases are due to the new positions that are budgeted and those grant positions and the 8 above base. And our PERS, fortunately, is for the retirement system remains the same at just under 30% at 29.75. Our services and supplies budget of $8.6 million is up almost $2.5 million over last year. Mostly that's for the professional services that we have contracted for the COVID-19 response. What we've tried to do is to have most of our staffing through temp agencies with only those staff that I identified as I was running through the different program areas that we've added as Washoe County staff under the COVID-19 response through those grant funds. Then we have the $375,000 that I mentioned previously on the name change and rebranding. Just under $200,000 that's on for 5 additional vehicles that we need to support staff and programs, and our vehicle maintenance costs that are associated. And then the amount of that increase, the $2.45 million, is offset by a little over $400,000 anticipated reduction in expenditures that we'll be seeing from solid waste management and air quality management restricted funds over the year. For capital improvements, we're level at $100,000. This is for the air quality program for air quality monitoring equipment for their monitoring networks. I would add we're chasing federal grant funding for hopefully be able to get that for a new monitoring station that we could put out in the Bird Eye area. But that's separate from this budget. The Washoe County Health District expenditures, the vast majority are for our people. When you look at the salaries and wages and our employee benefits pieces, 72.4% of our total expenditures there. The professional agencies, the orange piece of the pie, just under $4 million. And as I mentioned, almost $2.5 million of that is for the temporary staff services. The red piece of the pie, other services and supplies, also is larger than in the past because of some of the COVID response costs that are rolled into that. I mentioned that in the ODHO budget, we've got about $45,000 for our workforce development that's for district-wide. If you look at all of the budget that's incorporated for professional training, et cetera, within each of the division budgets, our overall workforce development budget is a little over $300,000, so about 1% of the budget. And then we do pay the county for the services that they provide to support the health district. So that's I don't know if that's teal or blue, the county general fund services at $1.85 million. Next slide, please, Susie. So To summarize the above base requests that we have in the budget, we want to support the rebranding of the health district name. We want to support the board's direction in increasing our workforce development activities. We also have the some of the reclassifications of staff because of work duties varying from what they were when they were hired. We have the positions that I mentioned, both the supervisor and the administrative support positions that are both intended to help address span of control, but also some of the workload issues that we're aware of for staff. And then I mentioned the new position, air quality, that's kind of contingent on the amended regulations that we intend to be proposing. We've got one-time funding that helps cover those positions, the vehicles that I mentioned, and the maintenance for those vehicles. Next slide, please, Susie. So when you get then into the sources and uses of funds, the fund balance at the end, as I mentioned, we have about $2.76 million deficit budget that we're proposing. And that's because we're looking at a ending fund balance of about $16.2 million at the end of this fiscal year. Then using this budget with that deficit at the end of the FY23 fiscal year, that would leave us with about $13.5 million in the fund balance. So that's 42.7% of our expenditures, which I know is a high fund balance still to have remaining. But I'd like to move to the next slide. Because when you look at the 3-year projection, what we're looking at is how do we spend the fund balance and invest in the health district in a more sustainable way than trying to spend it all down in 1 year. We do have the ongoing work that we'll have some professional services support on, further review on workload and span of control in the health district that we believe will be driving some additional positions we'll be requesting next year. But if you look at this projection over the next 3 years, you'll see that our ending fund balance does come down to 12.5% over that period, the 3 additional years. And I would also add that the funding that we got for the health equity and those positions that we've added, that's an important aspect of public health. It's now been added to public health accreditation. We've really learned how important that is through COVID-19 response. This budget here with these out-year projections provides continued support for those health equity positions beyond the grant that we receive. So I'm always hopeful we get more federal funding and we can adjust our budget in future years if we're able to secure that. But this provides for us to have a continuity of our focus and our development and assurance of health equity in Washoe County. One more slide, I think, Susie. So we're coming to you with the budget in February, which we always do, and it's a little early, but we are doing this because we're in a process where we're working with the county as well for our budget to be incorporated into the county's budget and the funding that they will provide for the health district. So there's a timeline that we'll go through where on March 1st, in accordance with the interlocal agreement, I'll meet with the city and county managers and present and discuss the budget with them. I will bring any comments, questions, concerns that they have back to the board at the March 24th meeting. On April 19th, the Board of County Commissioners will meet and they'll be discussing the county manager's recommendations for the FY23 budget. So we'll be working with the county's budget team and the county manager for incorporation of our funds from the county request into that budget. And So that general fund support from the county should be finalized in that report that's being presented. On May 17th, the Board of County Commissioners will have a public hearing and possible adoption of their FY23 budget. And then June 1st, the county delivers the final budget to the Department of Taxation. Next slide, please, Susan. So our recommendation is for you to approve the budget as presented. The approval today, though, as I mentioned, we don't know yet what the cost of living is going to be, the COLA allowance under the negotiations that are going on. There may be some other tweaks that happen in areas and costs for us through the county's budget process. So we may we expect to be making some adjustments prior to the final adoption of this budget by the Board of County Commissioners. But we think we've got the room to be able to do that, particularly with the news that the retirement health investment is not going to be as large as we had anticipated in this budget, but we'll report back to the board on any of those adjustments that are made to this budget, but it should stay very similar to what it's looking like now as it moves forward. And with that, I'm happy to take any questions.
All right, thank you, Health District Officer Dick. Is there any questions from the board in regards to the budget as presented? Councilman Dare.
Yeah, two. Just looking at the inflation that we're watching, that's one of the questions we keep bringing up in any board meeting we're having. Of just, I know that there's some room, obviously, but what are you anticipating? And then the other thing that I just have to ask, with knowing, I get the ending fund balance, I get the idea of us looking out 3 years, all those things are very wise. But we have some very real immediate needs now on some of our health assessment. Is that something we should look at? I don't know the right answer. It just cautions me to say, let's put all this money away for years to come, when I know we have some real problems, things we're working on right here in our community that is our responsibility to try to help. So thoughts I have, questions I have. Thanks.
Yeah, on the inflation side, I think we have that CPI increase that I mentioned that provides us with the revenue that helps to address those costs. But I think for the most part, we were looking at cost trends over the years, and I think that may be it's a legitimate concern on what we see coming in the future years. We've experienced that inflation this year. We've been able to live within our budget with it, so I think we're going to be okay over this next year, if unless something goes really crazy on the inflation side. On the use of the general fund, we're doing the new community health needs assessment right now, and that should be wrapped up by the May-June timeframe. The community health improvement plan will be coming from that. We do have the $500,000 that we can use to help support partners and initiatives that are identified there. But also with the new community health needs assessment and that community health planning process, we'll be doing a full update of the health district strategic plan this year by that fall timeframe. And so that, I think, would provide a good opportunity for the board to look at that and make decisions about other investments that they think are important to be considered.
I look forward to that, because I think that, like I said, we have all kinds of responsibilities of longevity, but also immediate needs. And we're all looking at this, obviously, in each jurisdiction as well. We don't need to try to step on anything, but we can maybe come alongside some of the work that's being done by the county and by the cities, and trying to make sure. Just some thoughts I have, but I would like that conversation as we go then, however that could look.
Any other questions from any of the members in regards to the budget? Health District Officer, I do have a couple of questions in regards to the budget. One discussion that I seem to keep ringing the bell on, but I don't know, and it does seem to be a little bit concerning to me, as Councilman Dare pointed out, that we're going to see a net change in that ending fund balance to the tune of 2.7 million. And with insurance costs, group insurance costs jumping over about 500,000 from previous years, from even all the way back to fiscal year 2016-17, we're seeing a $500,000 for the proposed insurance increases, and I would assume that we're going to continue to see those insurance premiums increase for our 200 plus members of the health district on an ongoing basis. One of the discussions, is there a possibility of, maybe this is kind of a layered question, with what type of revenues do we see from the permitting, the construction permitting and review through our, not just our environmental services, but also construction services? What kind of revenue do we see from those boards? I mean, from those divisions?
So those are the revenues that are rolled into the
for permits,
into fees and services. Yeah, and I would add a couple of things on that. When we established those fees, we worked hard to make sure that we were doing cost recovery for all of the costs of the health district. Mm-hmm. And so we looked at those indirect costs of, what is the insurance cost and those types of things. So that's all built into the hourly cost of an employee's time that's used to calculate those fees. And we're going to be revisiting those fees. We're doing some time studies now, and we're set to bring any adjustments that we identify that are necessary to those fees to the board, I believe December of this calendar year. So that'll be in progress. As far as the $500,000 increase in the insurance, I'm wondering if you're looking at the,
it's page 10.
I think it's the OPEB.
It's page 10 of the staff report under group insurance. For the last 5 years, we've seen that number rest pretty conveniently about 1.6 million, and proposed this year it's jumping to just over $2 million. And so it's not necessarily a net change of $500,000 to 400 and change. But I guess really ultimately what I'm trying to get at is that can those services be redirected out of the health district back to the entities such as Reno Sparks and Washoe County to their permitting and review departments, and so that there's maybe less oversight, less time spent on those review processes, and redirect and reallocate those funds to more necessary programming needed within the health district, i.e., as we've seen through the pandemic, our epidemiology response, our biologic response, our community health response. Can those types of services be reallocated? I'm looking at some of the redundancy within the community, and can we reallocate those funds?
I don't believe that that's something that we should be doing.
Okay.
Yeah, those are the responsibilities for public health for review of those functions, and those aren't things that our local construction permitting is doing.
Okay, I'm just trying to find some efficiencies and as you pointed out, we do need to identify ways to continue to increase revenues to those departments, and I'm just trying to find those redundancies that may be better reallocated to other entities that might not be as, I understand the importance of those. I just want to, if we can find some efficiencies with our partners within the community, how we can go about that. And so I'm happy to have that discussion with you and offline and see if there are some ways we can move that, because I would agree with you that some of the outreach needs to be refocused towards those greater programs and those greater needs as brought forward with Ms. Ratty's presentation earlier with mental health and different programs that we have seen become more apparent through the pandemic that would require the health district's attention.
Yeah, and I think an example of where we have done that, where it was a similar review process, and we worked to develop that review process to cover what needed to be done for public health, was with our work with Tumwa in the past, and with the update to the interlocal agreement this year to further expand that. But as far as the revenue from that, then helping the health district, we just collect our permit fees and service fees for the cost of delivering those services. So if we weren't delivering those services, we wouldn't be collecting the revenue for them.
Right, understood. So it's a net zero cost to us. So if we weren't doing it, we wouldn't be receiving the income from that. And so there wouldn't be any necessary benefit to the overall budget, what you're saying.
Correct.
Okay. Thank you. Any other questions from any of the board members in regards to the budget? Dr. Clacking, I see you.
Yeah, I just had one comment in regards to the insurance rates, and from something I have read is that the death rate during the 2-year period of the pandemic is up 40%. And this is an insurance company paper that I was reading, and that 3 Sigma change would be a 10% increase, and that would be a once in 200-year occurrence if it was up 10%. So I think you're going to see all these insurance rates jump pretty high.
Yeah, and where we're at with the insurance is the health district employees are covered under the county's insurance package. And so currently the insurance is through the end of this calendar year. And we don't yet know what changes may occur over the next period that's not yet negotiated on that insurance. So that's an unknown for us. But thanks maybe no thanks for sharing that statistic with us.
Yeah.
I believe that we, and Dr. Clacking, we are I know that the county is in current negotiations with not only our bargaining groups, but also our providers to try to secure long-term rates for the county through our self-provider plan. And so it is always an ongoing challenge, but something that the county does take, a lot of care and time into negotiating. So, all right. Seeing nothing further at this time, there are a couple of proposed motions in the staff report. And so at this time, I believe we need 2 motions to move forward with this. Ms. Reed, if I'm out of line, please stop me. But before we go to motions, I will go to public comment. So, Susie, do we have any public comment signed in?
We did have, just for the record, we had Ms. Cindy Martinez signed in, but I don't see her listed anymore. And then I also wanted to place on the record that Dr. Benko had to leave at 3:56.
Okay. Thank you, Susie. Is there any public comment from the callers or anybody on? No. Seeing none, we'll close public comment. I'm looking to the board now for a motion to approve the Washoe County Health District fiscal year 2023 budget as outlined by staff.
So moved by Brown.
Okay, I have a motion by Member Brown. Second by Councilman Dare. Call for the vote. All those in favor signify by saying aye. There is no need for the second motion because there is no amendments or adjustments needed, so we will move on. We will close this item. All right, Health District Officer, that takes us to item 16. This is staff reports and program updates. So with that, I will turn it over to you, Mr. Health District Officer.
Thank you, Vice Chair Lucy. Let's begin with air quality management. Mr. Vega.
Thanks, Kevin. Thanks, Vice Chair, members of the board. For the record, Francisco Vega, Director of the Air Quality Management Division. I don't have anything to add to my report, but I'd be more than happy to answer any questions.
All right. Any questions for Mr. Vega? All right. Seeing none. Thank you, Mr. Vega, for joining us today. Appreciate all your input today. And we will go on to divisional update. This is for the WIG program, and we have Ms. Lodritz on there. Lisa, how are you today?
Great. Thank you. Lisa Lottridge, Division Director for Community and Clinical Health Services, and I do not have anything to add unless you have questions for me.
Any questions for Ms. Lottridge? Seeing none for clinical and community health programs, we will close that item. We'll move on to item C. This is environmental health services. Ms. Dixon.
Good afternoon. For the record, Erin Dixon, Environmental Health Services. In addition to the report you have in front of you, I would just like to provide a very, very brief update about a town hall meeting that we will be hosting next Thursday in the County Commission chambers. It will occur from 9:30 to 10:30. It will be held both virtually and in person. And our team will be providing information in Spanish and English on how to obtain a mobile or temporary food permit and answering the community's questions. I'm going to share very, very quickly. Can you see my screen with the flyer?
We can, Ms. Dixon, thank you.
Okay. So good. In the fall, just as a little background, in the fall and through the early winter, we really experienced an increase in complaints regarding some unlicensed vendors. And we decided we needed to do some outreach in the spring. We thought it'd be good timing for the start of our summer temp food high season. However, we still had to continue responding to complaints. When we would go out on complaints, we would provide education on the reasons for permitting, which is to help prevent foodborne illness, and provide information on how to obtain a permit. And if necessary, as part of enforcement, we dispose of the foods that are considered high risk for foodborne illness. We responded to complaints on one vendor multiple times and did end up issuing a citation. This has led to an increase in social media attention. And the health district team has been able to participate in media interviews discussing the reasons why we are concerned with unlicensed vendors and how to obtain a permit. So we're excited to host this town hall and answer questions from the community. And if you have any questions regarding that or anything else in the report, I'd be happy to answer them.
Are there any questions for Ms. Dixon? Great job, Ms. Dixon. Looking forward to the town hall. Looking forward to be very informative. All right. Seeing no questions, we'll move on to item D. This is the epidemiology public health preparedness report. This is Dr. Dow.
Good afternoon, Mr. Vice Chair, members of the board. This is Nancy Dow, Division Director of Epidemiology and Public Health Preparedness. You have my report. I don't have anything to change or add to this report, but happy to answer any questions you may have.
Any questions from the board in regards to our emergency preparedness and epidemiology? Seeing none. All right. Thank you, Dr. Dow. We appreciate it. All right. And District Health Officer, your final report, sir.
Yes, thank you, Vice Chair. I've already provided my COVID update earlier, so I don't have anything else to add on my report. Happy to take any questions.
All right. Any questions for the Health District Officer? Final questions. Going once, twice, three times. So nobody gets it. All right. All right. Moving on. Thank you very much, everybody. We're on to item 17. This is board comments and announcements for any future requests for topics or agenda items. Are there any comments from any of the board members, those board members remaining with us? I'm going to add one thing. I do have a question that I'd like to see brought back in the March meeting, the Health District Officer. I would like a little bit more of a robust discussion in regards to the REMSA ground operations transport rate increase discussion. I believe that this is at this time, a very important discussion we need to continue to have. I know with the staffing challenges that REMSA is experiencing, along with most of the other industries within our community, this is a public health need. I'd like to move forward with that discussion about their rate increase. And so if we could bring that back for further discussion in March with the chair's approval, I'd like to see that on the March presentation. All right, seeing nothing further, ladies and gentlemen, thank you very much for staying with us all day. We do appreciate your attendance. Have a wonderful remainder of your Thursday and enjoy. We are adjourned. Thank you very much.